Hello and welcome to the Health and Government Operations Committee. Just a few reminders of our committee rules. We do have one question and one answer provided for members. The presenter of the bill will have 5 minutes to present the bill, and there will be 2 minutes each for up to 5 proponents, 5 favorable with amendments, and 5 opponents. The bill order has been listed in the chat. We're going to be starting with 11:30, then 11:48. 10:35, 11:11, 12:44, 13:55, 12:08, 12:41, 12:19, 13:18, and 13:82. So that's 11 bills today. We have 56 witnesses, and we will be taking our customary 15-minute break sometime around 3:30. So with that, let us move to the first bill of the day, which is Chairman Pendergrass, House Bill 1130, Health Occupations Prohibition on Expiration of Licenses, Certificates, Permits, and Registrations.
Thank you, Madam Chair. This bill should come as no surprise to anyone because we have all heard about and seen the pictures of the nurses wrapped around the building where they could get their licenses renewed, having to show up in person, and them sitting on the floor, on the sidewalk in the cold weather. And I'm sure that everyone was as horrified as I was at the way we were not able, the department was not able to help the boards come back from the departmental hack, the cyber hack that they experienced. So I don't believe that any human beings, but in particular our healthcare workers who are really doing incredible work these days, and we need them to do that work desperately to keep people healthy or even from dying, as it turns out, should have to go through that. So this bill is a bill that needed to get in by a drop deadline because I prefer to do that as opposed to have to waive the rules for the chairman. So it is a nice placeholder, and it may turn out to be more broad than it needs to be. There may be some boards that need to be treated differently because they have gotten back into working shape better than others. It may be that because this is not just for this incident, but it also could happen again. And I will certainly let the subcommittee work through their process of public input and make the bill what it needs. But this is a template for a beginning of what we need to do so that we're never put in that position again, and we never put those licensed healthcare professionals in that position again. So with that, I will say thank you. And whoever is next to testify, I actually haven't had a chance to look, so I'll leave it in the hands of the chair.
Thank you very much, Madam Chairman. We have 2 witnesses signed up to testify. First, we have Scott Tiffin.
Thank you, Madam Chair and members of the committee. My name is Scott Tiffin. I'm here on behalf of a bunch of different folks, but including the American College of Nurse Midwives, the Licensed Clinical Professional Counselors, NASW, and Maryland Community Health Systems. We are all very strong support of this legislation. A lot of our members have been having a lot of difficulty either renewing licenses or even getting initial licenses ever since the data breach happened. We've also heard a lot of complaints from healthcare facilities about difficulty verifying licenses. Even when different boards had different helpful extension mechanisms in place, it was sometimes helpful for hard for facilities to figure out whether one particular nurse or one particular social worker was actually eligible for any of those different temporary extensions. So we just feel that this bill will greatly improve the ability of folks to be licensed, to keep practicing, and prevent worsening of the current shortages that this committee is super duper aware of. We do have one small suggestion in our written testimony, and that is to maybe add like a 30-day extension for after the data breach is fixed, just to make sure folks have some time frame to get notice that they have to come back in and renew their license. So that was the only one small suggestion we had, but otherwise strong support and happy to answer any questions if anyone has any.
Thank you very much for your testimony. Let's hear now, even though he signed up favorable with amendments, this can be a short hearing. Let's hear from Matthew Dudzik, and then we'll go to questions since we know we'll be doing some work on this bill. Matthew Dudzik. He might be having trouble with his connection. So while we wait for him to reconnect, do we have questions from the committee? Delegate Rosenberg.
I don't know if this is perhaps best directed to staff. Is there written testimony from the department?
There is written testimony from the Board of Nursing, the Board of Physicians, the Board of Pharmacy, the Board of Examiners for audiologists, hearing aid dispensers, speech language pathologists, and music therapists, and the Board of Dental Examiners.
Okay, good. Well, so that's obviously available to the subcommittee as well as us. So yes, thank you.
Thank you very much. Delegate Cullison.
Thank you, Madam Chair. This is for Scott. Is there a defined period of when the breach is fixed? I'm unclear because it seems like this breach it just got longer and longer and longer. They claimed it was fixed, I think, like after 2 weeks, but then all the problems continued for months. So do you have a sense of what it means to be fixed?
I don't think I have a great answer to that question, in all honesty. I think it was at the beginning was hard to really understand what exactly the problem was. And then now it's sometimes, if you talk to different people at different boards, you get slightly different variations on what capacity they have right now. My one thought is I don't know if there's a mechanism by which there could be a report to DLS or a report maybe to like the cybersecurity committee in the General Assembly of like, this is where we are. And either DLS or the cybersecurity committee could somehow say, yep, that looks like you're able to process your normal capacity of licenses. You could look at how many licenses they could process in a week prior to the data breach and how many licenses they could process after the data breach. So I don't know if there's some way that could be reported to the General Assembly, and that could maybe be a check somehow on whether it's fixed. But I do agree it's probably a hard question to answer.
Thank you, Madam Chair.
Excellent. Delegate Hill.
Thank you. And I don't know if this is for the sponsor, Mr. Tiffin, but I'll try you, Scott. Obviously, we've got opposition from some boards who were saying that they were able to switch to manual. They were able to use a cloud-based system that apparently is not connected to the MDH system. Do you have any sense of what the boards that have been able to spring back and function have been able to do that the other boards haven't, or any sense as you talk to MDH of if they have an understanding of what builds resiliency and what doesn't?
So I think some of the boards have been able to, like you said, do manual processes or things like that. I know some of the boards, even before this happened, housed a lot of stuff off the whatever server was actually compromised to use other servers and things, and that has helped certain boards to get back to online quicker. For example, I know like the Board of Social Work, we're still hearing from social workers that although it seems like the board is back online and is able to process and do all the stuff they're supposed to do, there's just such a large backlog for during the several weeks where they weren't able to do things that people are still experiencing delays, even though the board is able to process at a normal or close to normal rate. So hopefully that kind of helps answer the question.
Thanks.
A question from Delegate Lewis.
Thank you, Madam Chair. Thank you so much, Chair Pendergrass, for bringing this bill. I was surprised to see a few unfavorable letters in the bill file from professional boards, the dental examiners, the audiologists, pharmacologists. That kind of amazes me because I thought that all the boards were struggling. So Board of Pharmacy rather. How do we make sense of that? They're saying that they don't believe that the bill is necessary. They say that the act of requiring notification of restoration of internet access, secure internet access, it's an impediment. So I'm really surprised by that, given what we heard in all of our hearings. And I'm wondering how to make sense of it. I don't know who's best to answer, maybe Mr. Tiffin?
And Mr. Tiffin, I will remind you that we do have Matt Dudzig from the Board of Physicians with his favorable with amendment, so he might also be able to shed some light on this.
Or anyone else. I wasn't insisting, I was just suggesting whoever is best.
I'm
Hang on
willing
back.
to take a crack at it if you
Yes,
like.
ma'am. Yes, ma'am.
I think that those are the details that have to be ferreted out in the subcommittee. I think that we have to understand exactly what the problems are. There may be a real variation between different boards. On the other hand, in case of another attack, different boards might suffer differently. So it has to be written carefully enough that it does what it needs to do to help the boards and not be an impediment. The intent is not to be an impediment, but it is intended to keep healthcare workers from having to sit out on sidewalks in the street in cold weather, because that was really terrible. It was truly inhumane, that picture. So with that.
Thank you, Madam Chair. Thank you, Madam Chair.
Thank you so much. I don't see any more hands up for this panel, but I do want to bring Matthew Dudzig back because I see he has reconnected. You can have your 2 minutes now. Thank you, Matthew. I think we're still facing some technical difficulties, but I know that we will be taking this up in subcommittee, so we will certainly have time to hear from him and discuss the amendments that may be necessary on this bill then. I think that's probably the best, giving him one more second just in case. I think that's the best, and we'll just adjourn the hearing and we have the file and we will talk to Mr. Dudzig in subcommittee because I know he has some helpful suggestions.
Thank you so much.
Yeah. I think that's it. I think we will adjourn on this one. So that it concludes the hearing on House Bill 1130, but we will take that up to address the details. Let's move on to House Bill 1148, which is also Chairman Pendergrass's bill, although I understand that Delegate Cullison will be presenting this bill. It is health insurance, two-sided incentive arrangements, and capitated payments authorization. Delegate Cullison.
Thank you very much, Madam Chair, for allowing me to present 1148 on behalf of Chairman Pendergrass. I'm going to briefly introduce the bill, but let the experts explain how it works. This bill builds on the successes of our total cost of care model by putting the focus of care squarely on patient outcomes in more healthcare settings. Value-based care, which is what this bill is about, is the basis for the global budgeting that we do with hospitals, but it's currently prohibited for our healthcare practitioners. Under this bill, if a practitioner or a group of practitioners choose to participate in this model, they will dramatically increase their opportunities to follow up and follow through with their patients to assure good outcomes. This is a model that is working well for both patients and practitioners in many other states. The bill is a product of nearly 20 meetings of a large, diverse group of stakeholders from the healthcare environment. Every aspect of this bill has been discussed, debated, and for the most part agreed upon, and I'm confident that we can work out the small differences. They have worked too hard to lose this opportunity. Please take time to read the written testimony. Perhaps the most remarkable thing you will see is the absolute support of all of the healthcare regulators. It's an impressive alphabet list: HSCRC, MHCC, MIA, and MDH. You also have letters from national experts talking about how value-based care actually works on the ground and some stats that show how people benefit from the focus on overall health. There is one amendment that we have ready for you today, and this extends the opportunity to behavioral health practitioners who ask to be included. Maryland is often the innovator in healthcare. Now it's time to catch up on how we approach the financing. The value-based care system puts the focus on financing directly to the benefits of our residents and we cannot understate the potential positive health outcomes in this model. It's an important change, and now it is time. I respectfully request your favorable report, and I will turn the rest of my time over to Brian Wheeler, who will explain the bill. Thank you, Madam Chair.
Thank you, Mr. Wheeler.
Thank you, Delegate Gullison, and good afternoon, Madam Chair and distinguished members of this committee. My name is Brian Wheeler, and I serve as the Vice President of Provider Collaboration and Network Transformation at CareFirst Blue Cross Blue Shield. I join you today to testify in favor of House Bill 1148 to expand the range of voluntary contracting options for healthcare practitioners and payers so that together we can create greater value and achieve better outcomes for consumers. This is one of the most consequential consumer-oriented pieces of healthcare legislation to come before this body. And why is this bill so important? Because what we have been doing isn't driving enough impact, and what we need to do isn't possible under existing Maryland law. Consumers and employers and governments that pay for healthcare are not getting the value commensurate with their investment. Quality of care can be improved, especially for the vulnerable populations, and many patients report that their experience with the healthcare delivery system needs some work. Many of our communities suffer from longstanding health inequities brought into sharper focus in the last 2 years, and some of our neighbors experience unacceptably poor outcomes. Consumers deserve more value. As the leader of the contracting organization for CareFirst, I seek to partner with the best performing healthcare practitioners possible so that members can seek the care they need in our network. The principal contracting tool I have at my disposal today is fee for service. Perform a service and get paid a contracted amount. People engaged in an array of businesses know a fundamental truth. Economic model drives business model. If revenue increases when more units are generated, more units will surely be generated. Any practitioner or health system's ability to transform their operations is hampered by a fee-for-service payment system. Generating revenue and fee-for-service is entirely linked to volume and not value, and this dependence on volume for revenue limits innovation. Exclusive use of a volume-based approach is fundamentally flawed in healthcare, driving up costs without pausing to reflect on outcomes. This legislation opens up the field of possibilities for willing payers and providers to innovate. These new contracting models, CMS calls them advanced payment models, create an economic environment where the best possible care is delivered more consistently over time, creating the highest value, best consumer experience, and best outcomes. It may be helpful to hear an example of how one of these models, enabled by this legislation, would work. Each healthcare delivery organization has an established pattern of performance. This pattern is measured in 3 key areas: quality of care, cost of care, and consumer experience. Metrics from these 3 areas form the starting point for a value-based contract. The health system and payer get together and come up with achievable targets for the next year. Once they mutually agree on targets in the best interest of patient care, those become the goals that drive incentives. Once the targets are agreed upon, the year unfolds, and we share data with the healthcare delivery partners so they can see how they're performing relative to goal. When the year closes out, we see where we landed. Were the quality and consumer experience targets met as agreed? If those targets were met, then we see if the total cost of care came in under the agreed upon budget. This sequencing, quality before cost, is important because we never want to have a situation where incentives cause reduction in medically necessary or appropriate care. That would be very short-sighted. Based on the actual performance against the targets we set together, we share in the risk and we share in the reward. Taken all together, these programs help us collectively slow the pace of growth in healthcare costs while continuously improving quality, so consumers share in the rewards too. Results become visible over time, which is why these relationships often take the form of long-term partnerships with healthcare delivery partners and payers collaborating very closely. I'm so excited that in addition to today's distinguished panel, the CEO of the National Quality Forum, a national health reform thought leader and fellow at the Urban Institute, several leading physician practices, and the region's largest health system have all joined in support of this legislation by providing written testimony. Each offers their own unique perspective, so I hope you have a chance to review them. Many of our partners are ready to move into new advanced payment models now, so I would be grateful for a favorable report from this committee. Thank you for your consideration.
Thank you so much, Mr. Wheeler. Let's hear from Brian Pennick.
Madam Chair, members of the committee, my name is Brian Pennick, and I'm the President and CEO of CareFirst Blue Cross Blue Shield. I join you today in support of House Bill 1148. Our healthcare system does many things well, but better is possible and necessary for the people of this state. But we will need more tools to get there. Value-based care represents a new tool for our state and an opportunity to take a step forward together as we work to improve the state of health for the people of Maryland. Value-based care is a simple concept. It rewards healthcare practitioners for improving health outcomes for their patients, while helping to make healthcare more affordable. It helps to enable healthcare practitioners as they work to deliver care in the most convenient and effective way for their patients, better addressing health disparities, and better aligning care with patient needs and outcomes. This is not a new concept. Value-based care is a national movement embraced by the federal government and Medicare, state governments and Medicaid, hospital systems, healthcare practitioners, and commercial payers with models in every state across our country. And it's working. It's working to support quality outcomes, to manage costs, and to make more affordable and accessible healthcare possible. This bill is the product of nearly a year of unprecedented collaboration with key stakeholders, including MHA, MedChi, health systems, and independent practices. It reflects our shared perspectives, establishing unparalleled protections for our healthcare practitioners while enabling innovative partnerships that advance health equity, improve patient outcomes, and reorient care towards population health. It also enables us to partner in ways that further the goals of Maryland's total cost of care program, creating better alignment across payment models. We recognize that every healthcare practitioner is unique. That's why this bill ensures that participation in these programs is completely voluntary. It is also essentially recognized that many healthcare practitioners are ready now and willing to engage in value-based care to help create healthcare solutions that Marylanders deserve and demand. We have world-renowned healthcare delivery in Maryland. We need world-renowned value-based care partnerships as well. Thank you for your time today.
Thank you very much. Next, we have Sean Kavanaugh.
Thank you. I'm Sean Kavanaugh. I'm appearing on behalf of Aledade. Many of you may not be familiar with us, but we're a company based in Bethesda, Maryland. And we work with independent primary care practices to help them move to value-based care. You've heard some great descriptions of what value-based care is. But just to give you some sense of our scope, we work in 37 states with 11,000 clinicians, and our practices in value-based contracts are managing the care of 1.7 million patients. We're proud to be based in Maryland, but also to have a network of physicians operating in Maryland trying to provide value-based care. I want to share with the committee that we think value-based care, including these two-sided risk models, is good for patients, good for practices, and good for society. Maryland's been a leader in value-based care with its total cost of care model, but to really engage the independent primary care physicians who are throughout our communities, we need more payment and complementary models, and I think this bill would allow for them. I want to assure you too, with this bill, you're not doing something that's out of step with the country. In fact, the opposite. We work in 37 states. We have two-sided risk models for Medicare, Medicare Advantage, commercially insured populations, Medicaid beneficiaries throughout the country. In no state that we work in are we prohibited for doing this by law. And these incentives are working. Our practices are providing more primary care and reducing total cost of care and improving the quality of care. Last year, we saved Medicare over $315 million, but we saved other programs over $146 million. And we do this not by stinting on care, but by making sure patients receive more primary care. A study of 5 of our markets showed our patients got 34% more primary care than similar patients throughout the country. And finally, this is good for the physician practices. When they get good at generating value, these models allow them to share in more of that value. So I encourage the committee to support this legislation. I thank you for your time.
Thank you very much for your testimony. Next, we have Cameron Matthews.
Good afternoon, Madam Chair and members of the committee. My name is Dr. Cameron Matthews, and I live in Washington, D.C., right next door. And I'm the Chief Health Officer for City Block Health, a value-based provider for historically marginalized and underserved populations. I'm here in support of House Bill 1148 to expand the scope of value-based care arrangements in Maryland. As a primary care physician, I firmly believe that health is more than just medicine. At City Block, we meet our members where they are. This goes beyond geography. It's a commitment to serving the whole person. We do this by taking a multifaceted approach that integrates medical care, behavioral health, and social services under one value-based care model to deliver positive outcomes at lower costs. Even more, we aim to understand and address any social determinants of health that impede a member's ability to live a healthy life. Take, for example, a 64-year-old patient with multiple chronic conditions who was recently exposed to COVID. We were able to treat him in a timely and safe manner via video consults, and our mobile care team was able to connect him with grocery deliveries and supplies for COVID symptom monitoring during his quarantine. This would have been a difficult concept to support and incentivize under current healthcare models. We are only able to deliver on this patient-centric promise in a capitated model, which allows us the flexibility to intervene and invest in dynamic ways that actually meet our members' complex needs while driving sustainable value. Since launching in 2017, we've seen great success with our care model in communities we serve across Connecticut, Massachusetts, New York, North Carolina, and next door in Washington, D.C. in partnership with Care First. For example, data from earliest member cohorts showed a 15% reduction in emergency room visits and 20% reduction in inpatient hospital admissions. This legislation would present an opportunity for providers like us and plans like Care First to serve high-need, high-cost members in Maryland. I urge you to vote in favor of Bill 1148. Thank you for your time today.
Thank you so much. And finally, on this panel, we have Molly Gelberd.
Hi, Madam Chair and delegates. Thank you for the opportunity to testify on HB 1148. For the record, I am Molly Gelberd, and I am here today on behalf of America's health insurance plans. The healthcare system has been working to transform to a value-based care delivery system for over a decade. Experience to date has brought many success stories and also generated lessons learned to inform future improvements. Thus, these arrangements are not new and are not new to Maryland, which currently permits care models with financial accountability or two-sided incentives in both the Medicare and Medicaid markets, which rightfully have been lauded for their successes in the state. As you've heard from other panelists, national trends tend to favor an approach to payment reform that incorporates a reasonable degree of financial risk into contracts in a manner that is sustainable, gradual, and voluntary. Public and private payer contracting, as well as leading policy experts in states across the country, have supported models with two-sided incentives rather than prohibiting them. The Healthcare Payment Learning and Action Network, or the LAN, which is a public-private partnership, measures value-based care adoption across public and private payers. Data has shown that adoption in these models has been increasing steadily year over year. In 2017, 33% of dollars were made through such a model, and by 2020, that amount increased to 40%. For providers, the benefit of a total cost of care model is that it provides them flexibility to choose how they deliver care, which might not be reimbursed under a fee-for-service system. This might include incorporating care coordinators to manage chronic disease or non-medical patient supports like nutrition counseling or transportation. And this serves in contrast to the fee-for-service model where providers are tethered to a set of codes that are covered and therefore reimbursable and may face pressures to see more patients in a shorter amount of time due to the focus on volume over value. A value-based system corrects these misalignments. Thank you for your time today, and for these reasons, we respectfully request a favorable report on HB 1148.
Thank you so much. We do have a number of questions for this panel. I was going to start it off by asking Sean Kavanaugh how great it is to work and have a business in Bethesda, Maryland's District 16, the best district. But instead, I will use my question for Dr. Matthews. How do the capitated models that you use give you the flexibility you need to meet your members' needs?
It's such a great question. Thank you, Madam Chair. Really, this is about understanding, I think, the larger complexity of what our members' needs are. And I think particularly with marginalized communities, it's about understanding the larger concepts of beyond an exam room, beyond in a hospital, but really what we call the social determinants of health and how they impact not only health outcomes, but also the cost of care. So really, I think even over the past 2 years, even the example I provided really shined a light on this, that in order to really address the needs of our members, again, grocery deliveries, transportation, housing, being three that we particularly focus on, it's really about augmenting those services in the community. And those are not typically billable services in a fee-for-service model. So really having the ability to have additional staff members focused on the broader concepts of health and not just the traditional medical care is how this model helps us.
Thank you so much. Next question is Vice Chair Peña-Melnick.
So I think, thank you, Chairman, that was my question, but I like Dr. Matthews. It seems like you have had incredible success. One of the issues that this committee, the priorities that we work on and care very much on is about the, improving health equity and reducing health disparities, right, in marginalized communities. Can you expand a little more about how you use value-based arrangements to improve this population?
Exactly, ma'am. This is personally critical for me as well as our company. I think really focusing again on those social determinants of health. We know particularly that a lot of these broader concepts of social care, as we call it, impact communities of color at higher rates. We also see broader concepts of chronic conditions, behavioral health diagnosis, inability to really get additional social support impacting the communities that are facing healthcare disparities at higher rates. So really being able to use the data to focus interventions to address social determinants of health and to have targeted interventions to these communities that face disparities. That's what this model is really going to be able to provide.
Thank you so much. And thank you for being with us today. Thank you, Madam Chair.
Next question is Delegate Kipke.
Thank you, Madam Chairman, and thank you to the folks on the panel. My question is for Brian Wheeler. When I first learned about this, I thought, well, it sounds really great, but everybody wants healthier, better, less expensive outcomes. But there's also the fear and concern that it could just be used to squeeze providers without it actually changing the outcomes. So my question to you is, when somebody is who has entered into this arrangement, when they're not getting there, things aren't going in the direction they're supposed to go. In other words, they're failing to meet the goals. Under this bill, is there any mechanism to warn them, to coach them? If you don't know that you're failing, that's no good. So, and then the follow-up, I'll just ask now. So, what is it to help them succeed? Then the follow-up is, what actions happen if they're not successful? Thank you.
Thank you for the question, Delegate Kipke. Obviously, something that's very, very important, and I'm glad that you asked. So there is an early warning system. In fact, this is standard practice, but it's also been provided for as a protection in the bill that payers who are in contracts with providers in relationships like this deliver data on a periodic basis. So I mentioned in my testimony that we have a set of goals that are mutually agreed upon between the provider and the payer at the start of a particular year. Then we need to track how we're doing relative to those goals throughout the year. So data is delivered on a periodic basis. We see how we're doing relative to target, and then have an opportunity to identify opportunities for additional intervention that may make a difference. If we're not tracking toward the goals, what kind of intervention might we make? Which patients need to come in to have gaps in care closed? What sorts of interventions might be done with referral partners? All of those things become possibilities for action and intervention to help the partner get on track for that year. The great thing about these programs is payers and providers are aligned more than they have been before. One wins, the other wins, and that creates the third win, which is for the consumer in terms of better outcomes. So the process of delivering that data on a monthly basis kind of goes into the second part of your question. CareFirst has resources that are available assigned to practices that are in these programs, a consulting team or a team that manages care across a larger enterprise and manages supporting that larger enterprise. They are the ones who are delivering that data and helping with that insights. We help to share best practices among providers so that when one comes up with a great workflow or intervention that's making a difference in the population, we can share it with others to help them be successful as well. And in this continuous improvement cycle, by providing feedback and feedback loop, providing data, and coming up with new interventions over time to get better results, we all make progress together.
Thank you so much. Delegate Kerr.
Thank you, Madam Chair. My question's for the other CareFirst Brian, Brian Pinnock. Brian, can you explain how this bill, the value-based care model aligns with the total cost of care model that we're familiar with?
Yeah, it's a fantastic question and really central, I think, to the progress that we're hoping to make here today. So consistent with the regulator's written testimony, we believe that it's incredibly complementary. So the Maryland health model's goal is to improve health outcomes while appropriately managing healthcare costs. Value-based care seeks to accomplish the same thing. And so this will allow the commercial market to more fully align with the state's efforts so that we're coordinating across unregulated payments as well as the regulated payments.
Excellent. Next question is from Delegate Lewis Young.
My question was just answered. Thank you.
Perfect. Let's move on to Delegate Morgan.
Thank you, Madam Chair. My question is for Molly Gilbert. You mentioned in your testimony about Medicaid and Medicare and the outcomes. Can you talk a little bit more about the outcomes of what those patients have experienced?
Yeah, thank you, Delegate Morgan. It's an excellent question. And I think that the Medicare Shared Savings Program offers a great example of some of the benefits of this model on a national scale. So the Medicare Shared Savings Program, or MSSP, is an ACO model, and it's the largest model to date and has arguably been one of the most successful. It's achieved savings in recent years, as AHIP's written testimony provides in greater detail. It's a total cost of care model designed such that participants gradually and automatically move into a more graduated risk track, just as the Maryland bill would provide a glide path toward accepting financial risk. And success stories include higher quality of care for patients of providers, such as higher quality performance scores, increased use of preventative services, declines in hospital readmission rates, more positive experiences based on consumer-facing surveys. Another example from a national model is a kidney care model where providers were responsible for total cost of care for kidney care. And results from that model showed a higher rate of primary care visits, increases in vaccinations, and a reduction in the overall use of opioids. Last example is from a national model also implemented by the Medicare Innovation Center that had multi-payer alignment where commercial plans were permitted to participate alongside. That was an oncology, or is an oncology care model. And that was associated with meaningful changes in the use of supportive care medications during chemotherapy treatment episodes.
Well, appreciate that answer. Thank you, Madam Chair.
Absolutely. Next up is Delegate Johnson.
Thank you, Madam Chair. My question is for Brian Wheeler. Brian, can you tell us how these contracts are designed to make sure that providers aren't incented to reduce care or not to accept or treat sick, complex patients, basically so they don't cherry pick?
Thank you, Delegate Johnson. Great question. When I was talking about the way that we set up these arrangements, the three things, the quality, the cost, and the patient experience, when we measure the cost, one of the things that we want to be careful about is not creating any sort of incentive for folks to not treat the sickest patients. So what we do is adjust the budget for a particular provider and their organization of patients to reflect the clinical risk that's actually occurring in that population. So if they have sicker patients that come into the practice over the year, their budget would increase along with that, with those sicker patients. Or if they have existing patients that have new diagnosis that come in throughout the year, that goes up. The budget then goes up alongside of that. So it's really important that we're measuring and managing the risk in the population and helping the providers understand the risk in their population. That's where the opportunities to do better come from. Oftentimes, the practitioners don't know about some of the risks, and if we can use the data to help to show them, that really does help them to do a better job of managing their populations. I hope that's helpful.
Somewhat. Thank you, Madam Chair.
Delegate Bagnall.
Thank you, Madam Chair. And whoever would be most appropriate to answer this question. But we talk in this committee a lot about recruitment and retention of providers, particularly of specialized services. And can anyone speak to any trends or impact that you've seen in terms of recruitment and retention efforts, for providers operating under this model?
If it's okay with the committee, I can respond on behalf of Aledade.
I was going
Again,
to suggest, yeah.
okay. Again, a reminder, Aledade works with what are called independent primary care docs. So these are not owned by health systems. They're the, essentially small business people who, and half of our practices across the country are 10 or fewer physicians. So think of the traditional several doc practice. Frankly, that's a dying breed, meaning it's getting harder and harder to be in business in that model. But what we find is if we can move them to value, if their opportunity isn't to do another 7-minute visit with someone, but to really manage the patient that they see and to focus on the ones who are the neediest and generate real value to the health system and then get paid for that. One, it's the type of care they were trained to deliver and they really want to deliver rather than churning patients through. But it literally makes their practice financially viable in a way it has not been in the past. So we're very proud, like we've been growing very rapidly and we've lost very few of our practices to the national phenomenon, which is people selling their practices to the local health system or retiring early, including during the pandemic. Our practices did quite well in value-based care during the pandemic because they shifted how they delivered care to telehealth. And so I appreciate the question. And I very much think value-based care can be a way to retain the independent workforce that we have today.
Thank you very much for that answer.
Delegate Hill.
Okay, thank you, Madam Chair, and thank you all for being here. Some of my questions have been answered, so I'm going to just stick with this one. It's really not clear to me, and I've looked at these models and read a lot about them, who gets to determine what value is. And I think people often confuse value with quality. And I'm not clear on under this bill how we would be sure that the patients who are our constituents are receiving quality care and not simply value as defined by the bottom line. So who gets to determine what the value is and what input do providers have in determining what should be measured in looking at outcomes?
Mr. Wheeler, maybe? Mr. Wheeler?
Thank you very much, Delegate Hill, for the question. The bill actually provides for the fact that any performance measures, including the source of the measures, be negotiated between the parties in advance, and that we specify the time period that we're going to use for measurement. Typically, what we use are national standard measurements. One of the folks who submitted written testimony today is the CEO of the National Quality Foundation. NCQA is another source of measures for us. So these are things often around focused on chronic disease. A number of the measures are focused around proper management of diabetics, of hypertensives, also all of the closure of screenings, gaps in care. So things like mammography and colonoscopy, so that we're making sure that folks have early detection and are able to hopefully avoid any poor outcomes. So these are the types of things that are built in. And we think that the combination, and in fact, this is CMS's definition of what's called the triple aim. It's better care, better cost, and better patient experience. So the combination of those three things is the generally accepted definition of value in the space at the moment. Is that helpful?
It is. May I have a follow-up or you need to move on?
Sure, go ahead.
Okay, thank you. So you mentioned negotiations, and typically what we find in insurance negotiations with providers is it's not really negotiated. It's a take it or leave it. And if providers don't want to take it, they don't get the black line. They don't really have negotiating power unless they combine in large masses like our huge neurology, orthopedic groups, et cetera. So there's less competition because they come together to have market force against the insurer. So when you say they negotiate on what those parameters are that are going to be measured, is it a different model of negotiating than currently is used by the insurer?
I think so. It gives us another tool in the toolbox. Today we have one tool, which is fee for service. If we're able to take fee for service and include a number of different performance incentive opportunities in the types of models that we're talking about here, it gives us all more flexibility. If we've had this, in the last year, different partners come to us and say, hey, I've got an idea of something new that we can do and do differently. It requires a different mechanism for financing. Would you be interested in that? In some cases, we've been able to do it under existing law and able to make some progress. In some cases, we've had to say, At present, it's not permitted in Maryland, but perhaps we can revisit in the future. So I think it's all about expanding the range of possibilities for contracting beyond the sort of the way that we've been doing it for decades, presenting some new opportunities for innovation.
Thank you. Thank you, Madam
Of course.
Chair.
Excellent. Delegate Saab.
Thank you, Madam Chairman. Nothing sounds better than a quality, affordable healthcare with a fantastic patient's experience. I have a question for Sean. And I was looking over your testimony and in your written testimony, it looks like you were successful and able to increase your access to primary care and improve health outcomes for your patients under the two-sided agreement compared to other practices in committee. Can you explain to us how this arrangement helped you do that and tell us more about the outcomes?
Sure. Thank you for that question. Yeah, we tried in our written testimony to show you real evidence that this works. And one of them was a study we did in 5 very different markets. We compared our patients to similar patients and showed that our patients had significantly more primary care that led to significantly fewer ED visits, significantly fewer hospitalizations. And that generated total cost of care savings. Now, a number of the questions here we've heard today is, is this really a negotiation or is it just being ran down your throats? In the old days in fee-for-service, that was the negotiation, and the payer and the patient and the physician are all on different sides, butting heads. But once you enter into these two-sided risk models, all of a sudden we're on the same side. The payer needs us to be successful. We need the practice and the patient to get better, because if they don't, no one's benefiting. And so I'm not pretending this is a cure-all, and it, but it is definitely eases a lot of the tensions in the health system. It makes opportunities, bringing alignment across people who've been butting heads for so long, with our patients suffering the most. So that's why we support this. We think, the evidence is accumulating that these really work. And the reason the two-sided risk is important is, as our doctors get good at this, they're generating more and more value. They want to share in that. They don't want it all to just accrue to the health plan. And the health plan is willing to share if we're willing to take some of the downside risk. And I think once we have some experience, we're happy to do that.
Thank you, Madam Chair. Can I just have a quick follow-up question? I know you mentioned something about thank you. I know you mentioned something about the contracts and the negotiation. Are they, and I don't know if I missed this, and you probably know the answer, how often are these contracts for? Are they like annual, or are they every couple of years? Or are they different based on each provider?
They do vary, but I would say the typical one is usually 3 years.
Okay. Okay, perfect. Thank you. I appreciate it.
Thank you. That's the last question for the favorable panel. We're going to move on to the favorable with amendments panel. First up is Lori Doyle.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland in support of HB 1148 with amendments. Reimbursement mechanisms are not inherently good or bad, but they can and do alter provider behavior through incentives and disincentives. Our current reimbursement mechanism, fee-for-service, incentivizes volume. So the more services we provide, the more reimbursement we get. It does not incentivize outcomes, nor does it allow much flexibility. We're held to the strict confines of the CPT billing codes. And from a behavioral health perspective, that's problematic. Behavioral health conditions wax and wane. There are periods of progress that are often interspersed with periods of relapse. Providers need the flexibility to provide more intensive and creative interventions when needed and to back off when not needed. I would note that capitation is not new to behavioral health. For years, I oversaw one of the 2 capitated Medicaid behavioral health programs in Baltimore City. They serve only high-need, high-risk individuals who had multiple behavioral health hospitalizations or long-term institutionalization. These were individuals who often had co-occurring medical and substance use disorders and great needs in social determinant area, housing, food, and transportation. Many also had forensic histories. The outcomes of this program were remarkable because we had the flexibility to meet the person where they were. We were measured on various outcomes, and if we met those outcomes and managed to come in under the cap amount, we could reinvest in our workforce and reinvest in our services. Our provider network supports this bill because we know that what we do works, and we'd like the opportunity to be rewarded for that. We worked with Care First on amendment language, and we thank them and we thank the sponsor for including those amendments in the sponsor amendments. So we urge a favorable report on this bill with that amendment language. Thank you.
Thank you very much. Next, we'll hear from Gene Ransom.
Thank you, Madam Chair, members of the committee. MedChi is very supportive of value-based care, as is the physician community. In fact, we've been a leader in developing and implementing both the Maryland Primary Care Program and the Episode Quality Improvement Program, two very successful value-based programs under the all-payer contract. And who better to manage value-based care than physicians and practitioners who focus on quality and outcomes for their patients every day? Our concerns about this legislation have always been the risk that is being shifted to patients and physicians. Physicians and patients are not equipped to manage risk. We have worked tirelessly with the insurers and other stakeholders to improve the protections and the problems with this legislation from last year. And we're very proud of that work, and we're very happy that we're almost there. I'm not going to go through the numerous changes from last year's bill, other than to say we have always had two major concerns for physicians and patients. One has been the amount of risk that should be transferred to physicians and patients from insurers. And the second has been protections in the form of a payment floor for practitioners who decide the model isn't for them. The risk issue has been mostly addressed from last year's bill, thanks to an agreement we made during the negotiation. Risk is capped at 10%. And while that risk is a little more than what's in the EQIP and the MDCPP program, we can live with that. The floor issue is still not quite resolved. Given the market power of certain insurers, protections are needed to make sure physicians are not punished for deciding these models are not for them or their patients. In both EQIP and MDPCP, there is a clear hard floor. Those are both Medicare programs, and the physician can simply go back to the Medicare fee schedule. We don't have floor language worked out in this legislation. MedChi and insurers need help closing the gap on how to resolve the floor language. MedChi is particularly concerned that the insurer's proposed language allowing only a complaint when solely due to value-based care could essentially negate all the language. I just want to reiterate, this support with amendments is support with amendments. We want to get this bill done. We want to work through the last issue, and we really appreciate all the time and effort that everybody has put to getting this in the right place. We urge a favorable report with amendments. Thank you, Madam Chair.
Thank you so much. Next up is Daniel Shattuck.
Good afternoon, Madam Chair, members of the committee. My name is Dan Shattuck. I'm here today on behalf of the Maryland Society of Anesthesiologists, U.S. Acute Care Solutions, and U.S. Anesthesia Partners. I'm going to echo what Mr. Ransom just said. We are in support of innovation in value-based care. These specialties in particular have been leaders in coming to the fore with ways to improve and provide additional value to the care that they provide. We are urging passage of the amendment, which is in our testimony and in MedChi's testimony. And what this amendment is doing, it's providing protection for all providers who treat a patient who may be part of a two-sided risk model, but that provider is not a direct participant in that risk model. And because value-based models seek to address a patient's total cost of care, there will be circumstances where that patient is going to receive care from a provider that is outside of that arrangement or that model. The language we've put forward protects those providers and takes them out of any risk or loss of fees or any reduction in fees simply because they cared for a patient who is in that model. Instituting protections at this level for all providers at the front end of the model will really help with the success and the long-term goals of the model. Ultimately, for value-based care models to succeed and to be meaningfully available to all patients across the healthcare spectrum, we need to have protections in place for those providers who choose to be in the model, who choose not to be in the model, or who may in the course of their providing care interact with a patient who is a part of the model. So we ask for favorable consideration of this amendment. We look forward to continuing the discussions in subcommittee and beyond. And thank you very much.
Next, we will hear from Barbara Bricado.
Good afternoon, members of the committee. Barbara Bricado here in support with amendments on House Bill 1148 and on behalf of a number of our clients, in addition, anesthesia, and large groups, large Maryland groups, emergency physicians, otolaryngology. So, what I want to say is that we've been knocking at the door to be part of innovation here in Maryland with our clients going back to before 2010 with triple aim, with the beginning of total cost of care. I will say that we were knocking at that door. We weren't let in, or our provider clients were not let in for a while. We were told, we have to work this out with the payers. We have to work this out with the hospitals. We'll get to you. We promise we'll get to you. We get to you. We get to you. I always thought that was backwards. I always thought we needed to start with the hands-on providers that are providing care, that know the quality standards, that we shouldn't be an afterthought. These new models are important. They're untried. They need appropriate guardrails. They need appropriate protections for the patients and to ensure that quality providers are willing and able to participate so that the outcomes are the best they can be. So with that, I just say, this is complicated. We have to be careful. As I've said, our clients have gone over these past, 12 years. We've gone to the hospitals, we've gone to HSCRC, we've gone to the payers, we've gone to them with models such as a perioperative surgical home to provide I'm over. All right.
You can just wrap it up very quickly.
I will just say, I look forward to having more discussions and participating in discussion in these discussions. And I thank you for your time.
We do have one witness signed up as unfavorable, but let's go to questions first to the favorable with amendments panel. Any questions from the committee? Don't see any hands up from the committee. I did have a question for Lori Doyle. Lori, in your written testimony, you mentioned that the flexibility that this allows, that these models allow could make patient needs more readily met. Can you explain that a little bit more?
Sure, and thank you for the question. Currently, we're bound to CPT codes, the billing codes, and they are very prescriptive. They tell you basically who can do it, what the service is comprised of, what duration it is paid at. And so from the behavioral health perspective, for instance, if we have a member who could really benefit from the visit of a community health worker or a peer, someone who has lived experience with mental health or substance use disorder, that would probably not be reimbursable under fee-for-service CPT mechanisms, but it could be very valuable to the person we serve. So what we've seen with these flexible arrangements is we can not only think outside the box, we can think outside the code, and it's very important for behavioral health.
That's really helpful. Thank you very much. Delegate Hill.
Thank you. I guess I'm gonna, either Jean or Lori, the question that I asked the previous panel, when they talk about who determines what parameters are being measured as giving value, right? Is it admissions, discharge, or whether people are readmitted? And if they're readmitted, what level of acuity, ICU or otherwise? The answer I got is those are negotiated as the contract's written. You may have heard my response that's, I'm skeptical of that. Do you have, I guess it'll be for Jean, is there any concern? You've been negotiating this with them for a while. Is there any concern that this is a David and Goliath negotiating that providers would be entering into, and that better protections need to be in if this is going to move forward, that there's true negotiation about what value and how value is defined and measured?
I think you've hit really the last issue we have left right on the head. Is the key is that there is a bargaining imbalance, that one carrier in this market has a very large market share, and physicians really, it's very difficult for them to leave that market. A doctor can't say, I'm not going to participate with that one particular carrier, because if they don't, they can't run their practice. And it particularly hurts smaller practices in smaller areas and underserved areas. And we think the key is, and what works really well with both the two Medicare value-based programs, EQUIP and MDPCP, is the physician has a choice. They can participate or they can leave, and they know they're guaranteed to get that Medicare fee schedule, which becomes a floor. So we're trying to build a floor out, and in fairness to the carriers, they have tried to work a floor out with us. There's some language around that, and the issue is there's just not a solid floor at this point in time. And some of the practitioners who will never participate because of the nature of how they practice want to make sure that they're protected as well. And if you look at the amendments that we've offered in our written testimony, that's what we're driving at, is putting that last protection in to solve it. And again, I want to reiterate, Dr. Hill, you know, we've had tensions with the insurers in the past, and often in this committee, you see us fighting, but the work that we've done has been in good faith. And a lot of the concerns that you're bringing up, we have addressed, and we've addressed with amendments, and they've worked with us on them. We're really down to this one issue, and I'm hoping in subcommittee that the subcommittee can figure out a way to look at the concerns that we're raising about the floor and the floor language, and look at the concerns the carriers are raising about the floor language, and see if they can figure out something that's fair and reasonable to make sure that the small practitioner in Capitol Heights, who happens to still be in private practice, who has no bargaining power whatsoever, has a protection of having that floor that they can stand on if they decide value-based isn't for them. So I feel like we're really close. We're almost there, and I really would like to see us figure this last bit out. And I think you hit the nail right on the head with your question.
Thank you, Madam Chair. Thank you.
Absolutely. I don't see any more questions for this panel. So let's move on to the unfavorable, which is Dan Doherty.
Thank you, Madam Chair, members of the committee. I'm Dan Doherty here on behalf of the Maryland State Dental Association in opposition to HB 1148 as it applies to dentistry. When the predecessor bills were introduced last session, House Bill 1021, we had never been approached by anybody from the proponents and knew nothing about it until the bills were introduced. They were then withdrawn, and it was very widely known that the negotiations were going to be limited to physicians. And as late as December, we were told that it was still physicians. And then the bill is introduced, and now it applies to dentistry. This type of model does not work with dentistry. Dental insurance is unique compared to major medical. Everybody has dental disease. Everyone needs care, and most dental insurance puts annual caps on what that care is, usually $2,000 or less. It has been attempted to deal with the issue from the insurance standpoint of capitation, and that has led to catastrophic financial results for many dental practices because they end up bearing all the risk of the adverse selection of those patients who've ignored dental care until they finally have insurance. We believe that due to the nature of dental disease and dental insurance, capitation exposes the dentist to great financial risk. It is insurance risk that is passed downstream to dentists, and we believe improperly. I would note that in dentistry, there is no Medicare floor. Dental coverage is not provided under Medicare. Therefore, there is no fail-safe to go back to. Because we were not included in discussions, because dentistry is unique in terms of everyone has dental disease, and because dental insurance is different, we would urge that as far as dentistry is concerned, this is given an unfavorable report, or at least viable amendments are used to exclude dentistry from the scope of this bill. Thank you.
Thank you very much. Questions for Mr. Doherty? Don't see any hands up from the committee, so I thank you so much for your testimony and everyone's participation. That concludes the hearing on House Bill 1148. And we will move on to House Bill 1035, which is Delegate Pena-Melnick, Health Insurance Qualified Resident State Subsidy Program, Access to Care Act. Delegate Pena-Melnick.
Thank you, Chairman and members of the committee. It is an honor to present to you House Bill 1035. The pandemic has shown that Maryland's communities are healthier and stronger when everyone has the resources that are needed for themselves and their families. We learned that, we lived it for the last almost 3 years. And since the adoption of the health benefit exchange by the state in 2011, the state's uninsured rate has been cut in half. And in recent years, hundreds of thousands of Marylanders have successfully obtained coverage through the exchange. Despite this success, however, more than 300,000 Marylanders still remain uninsured. So there's a lot more work to do. While the state has made great progress in providing access to care, the largest population left behind is the undocumented residents. While multiple states have established similar programs like Medicaid expansion and public options, we have not addressed this population. Approximately 275,000 Marylanders, that's 4.5% of the population, are undocumented residents, and nearly half of these residents are uninsured. Options for health insurance coverage for undocumented residents are largely limited to emergency services through Emergency Medicaid and the Emergency Medical Treatment and Active Labor Act. They depend on safety net hospitals and the FQHCs for some financial assistance with other hospital services. There's really nothing there for them. Many uninsured residents delay care because of this until the last possible moment due to the lack of coverage. Many undocumented residents must go without coverage and remain relying on emergency care, which is costly for all of us because of the uncompensated care and the model that we have, and it affects all our premiums. Due to such delays in care, uninsured patients face more severe health problems in the long term, which again are very costly. What the bill does, it opens the health care plans on the Maryland Health Benefit Exchange to all Marylanders who meet the regular requirements for the ACA eligibility, regardless of immigration status. Right now, they can't even purchase from the exchange if they're able to. It opens the Maryland Health Benefit Exchange to all qualified residents, which include individuals who are not incarcerated or eligible for Medicaid, CHIP, or Medicare. It creates a framework for the state subsidy program. It gives a lot of flexibility for the Maryland Health Benefit Exchange. It actually requires, again, that the Maryland Health Benefit Exchange apply for a 1332 waiver so we can get some federal pass-through money. It improves access to care by opening the exchange to all uninsured Marylanders. This will reduce, again, our premiums. You may ask a question about, well, look at the fiscal note. It's very expensive to do. Well, the fiscal note, what you see there is that it actually takes the most expensive scenario, which is to cover everyone. And according to the Maryland Health Benefit Exchange, which this bill is modeled after, we're really following their footsteps. It's 52,000 people that can be covered under that scenario. That's everyone. But the exchange doesn't have to do that. It actually has flexibility, and the bill in the bill on page 8, line 17 says, based on available funds, the exchange in consultation with the commissioner as approved by the board shall establish subsidy eligibility and payment parameters. That means that they can do what other states have done, which is to place an age limit. They can also place a limit on the federal poverty limits as well. So the exchange has a lot of flexibility here. What the fiscal note does not take into account is the savings that we will have when people stop going, uninsured people stop going to the hospitals, and when you provide preventive care. So this is good policy, and we have done great to cover everyone else. But the fact is that if this population does not have insurance, it affects all of us. And if we were to cover them, it will reduce our premiums, and it will also give them a healthy life. And it will be good for all of us in the end. Thank you so much. I hope that we have a favorable report on this bill.
Thank you, Madam Vice Chair. We do have a couple of questions. Would you like to do the panel of proponents or go to the questions first?
If we could do the panel of proponents, and I know that Michelle Everly from the Maryland Health Exchange is here for questions as well.
Excellent. So the first proponent is Michelle LaRue.
Thank you.
Madam Chair, members of the committee, my name is Dr. Michelle LaRue, and I'm the Director of Health and Human Services at CASA, Maryland's largest immigrant rights organization. CASA asked the committee for a favorable report and to prioritize this legislation that will allow undocumented immigrants a chance to buy insurance on the exchange. And we deeply thank Vice Chair Peña-Melnick for her leadership and commitment to immigrant families. Everyone deserves health care, regardless of their immigration status, and this is at the core of this bill. The majority of the people who enter our doors at CASA are undocumented and uninsured. Just this past year alone, CASA administered nearly 20,000 COVID vaccines, and it assisted 25,000 others navigate the Health and Human Services system. We work tirelessly to ensure that immigrant communities are receiving the care that they need. These services are in such high demand because our community is entirely ineligible for coverage and must rely on overwhelmed safety net providers. Despite paying approximately $350 million in taxes, state and local taxes each year, they can't buy insurance on the exchange, even if they can afford to buy the plan at full cost. Committee members, as you know, these individuals contribute so much to our state outside of their tax contributions. They are weaved into our community. They've kept us afloat during the pandemic, working essential jobs, and we cannot leave them behind now. Maryland has taken great strides in prioritizing health equity and being a leader in embracing reform, leading to an almost 50% decrease in the rate of uninsured. Yet still, little has been done to address access to care for the nearly 5% of our population that remain undocumented and uninsured. This bill would correct that injustice and allow access to the marketplace for all Marylanders, as well as to begin to create a framework for a subsidy that would make the plans affordable. Insurance providers, hospitals, community clinics, and the entire immigrant community are all in alignment. It's time to make this happen. For these reasons and many more, we strongly recommend a favorable report on HB 1035.
Thank you so much. Next, we have Monica Vasquez.
Hello, Madam Chair. Thank you very much. My name is Monica Guerrero Vasquez, and I'm here to represent Centro Sol, the Center for Health and Opportunities for Latinos. Thank you for the opportunity for allowing the express our support to this bill. I'm going to tell you the brief story of Brenis. Brenis is a young man of 34-year-old man who came to the U.S. when he was 20. He had an accident, and with a lot of pain, he still goes to work. He contributes and pays to the taxes. Like Brenis, thousands and millions of individuals have contributed thousands of dollars to our economy. We know that Maryland is one of the most diverse states in the country. However, we're not growing at the same pace in terms of services and healthcare that we have to provide to our community. Expanding access to healthcare will provide an opportunity for individuals like Brenis and his family to receive timely care and reduce hospital admissions. Brenis is scared to go to the hospital. Brenis is scared to seek for care for his pain after his accident, and he's still going to work and paying taxes. With this bill, rates of hospital admissions for preventable conditions will be reduced. As we know, these rates are higher among undocumented immigrants. This bill will expand, as we have heard, state premium assistance and cost sharing reductions to individuals, including minors, regardless of their immigration status. This bill is urgent and needed a public health intervention to protect the health of one of the most diverse, rich, and fastest growing community, and yet one of the most marginalized and vulnerable populations in our state. It will also ensure that our hospitals are able to handle emergencies by reducing hospital admissions of individuals with preventable and medical conditions. For these reasons, Centro Sol supports this bill and urges a favorable report on Bill HB 1035 SB 728. Thank you very much.
Very much. Next, we'll hear from Stephanie Clapper.
Thank you. I'm Stephanie Clapper from Maryland Citizens Health Initiative, and I thank you for this opportunity to testify in favor of this legislation, and special thank you to Vice Chair Peña-Melnick for being the lead sponsor. Under your committee's leadership, Maryland has the 5th best healthcare system in the entire country. On behalf of the Maryland Healthcare for All Coalition, I urge you to give a favorable report for House Bill 1035 to bring us up to number 1. Our organization has shared in detail why we are in support of this bill in our written testimony. So instead, I have the honor of sharing the testimony of a CASA member who could not be here today. His testimony is as follows. My name is Raphael. I am a CASA member. I'm a 20-year-long resident of Rockville. I'm an immigrant from Nicaragua. I'm undocumented. I'm uninsured. But most of all, I'm a person. And I believe that every person, including me, deserves health care. I support this bill that will allow people in my community to buy health insurance through the Affordable Care Act that we are currently not eligible for. This is my story. One day at work, I got a fever. I left early and knew something was very wrong. Like most people without insurance, I was afraid to go to the hospital because I knew I didn't have the money. Eventually, things got so painful that I had no choice. I found a private clinic, they ran a few tests, and then my worst nightmare. I was diagnosed with a kidney condition. I needed a specialist multiple times a week to get treatment. $50,000. That's how much it cost me out of pocket. After 8 months, a doctor told me it was more than just my kidney. I had another underlying issue. At that point, I had to stop treatment. I used every cent of my savings. The clinic took pity on me and awarded me temporary charity insurance to help me finish my sessions, but I can't imagine if something worse had happened. These sorrows are experienced and suffered by most immigrants. Many immigrants are often left with no choice but to take on labor-intensive jobs with high risks and are often left with little to no benefits, pay, and protections. Montgomery County offers some good support, but it's not enough. We need an option to purchase full health coverage. When you debate and consider this bill, please think of me and my community. Thank you for your time.
Thank you so much. Next, we will hear from Christine Crone.
Good afternoon, members of the Health and Government Operations Committee. For the record, I'm Christine Crone here on behalf of the Mid-Atlantic Association of Community Health Centers and the Maryland chapter of the American Academy of Pediatrics in support of House Bill 1035. This bill would allow Marylanders, regardless of immigration status, to participate in the Maryland Health Benefit Exchange if they were otherwise eligible for the requirements under the Affordable Care Act. As providers who serve in the community regardless of payment status, there's a clear evidence that this population suffers from lack of access to needed healthcare services, which results in higher hospital rates and poor health outcomes that not only negatively impact these individuals, but also increases healthcare costs for the state overall. Passage of House Bill 1035 will not only dramatically increase access to affordable coverage for one of Maryland's most vulnerable populations, but will also lower overall healthcare costs and individual market premiums for all of Marylanders. A favorable report is requested.
Thank you. Our last witness is Allison Taylor.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente today. Kaiser Permanente offers health plans in the Health Benefit Exchange, and we serve over 450,000 patients here in Maryland. I got a call last fall from a member of the House of Delegates asking if I could assist with a problem with coverage for a Kaiser member. And it turned out through working through the issues that it was someone who was not able to receive coverage through the exchange because of their immigration status, and as a result, they had lost their Kaiser coverage. We tried a number of things to try to keep this person on that plan, but because of current law, we were not able to do that. So, in other states where this has passed, Kaiser has been at the table. We serve undocumented patients in California and will be so in a number of other programs that are coming online, including Colorado, Oregon, and Washington. So just want to say we support this, and we're happy and willing to be at the table with the state to figure out a way to make this happen here. Thank you.
Thank you so much. And thank you to the members who've been waiting patiently with their questions. Delegate Morgan.
Madam Chair, did you just call me? I'm sorry.
I did. We're ready for your question now.
Gotcha.
Thank you.
Thank you, Madam Chair. I guess my question is for the bill sponsor, Delegate Pelnelmek. So with this new group, would that be eligible for the reinsurance?
This bill does not deal at all with a reinsurance program.
So the new group that this would set up, I mean, it's basically setting up another group. It wouldn't be
right, but the bill does not deal with that. The bill basically does two things, Delegate. It allows the Health Benefit Exchange to request a 1332 waiver so that they're able to purchase from the exchange, which presently they're not able to purchase because they are undocumented. Secondly, it gives the exchange the flexibility to establish a basically a framework for the subsidy program. It does not mention anything about the reinsurance program. However, I can tell you that there's a bill that this committee is presently entertaining and will be passing that will prohibit touching the reinsurance program. You can also ask Michelle Everly, who's here for questions, to address that question since she's the executive director, but this bill does not deal with that.
Okay, thank you.
My
Thank you, Madam Chair.
pleasure. My pleasure.
Delegate Lewis.
Thank you, Madam Chair. And thank you so much to Vice Chair Pena-Melnick for bringing this important bill, this public health and human rights bill. I'm curious about the fiscal note. I did go in and read through it. And as you admitted in your testimony, it does involve a fair amount of money. Yes, as you mentioned, it's also true that the exchange can be flexible in the terms that they use to define eligibility. That could change the number of people eligible and the ultimate cost. But I'm still curious, knowing that undocumented people living in our state are Marylanders, and knowing that they work, that we all came to understand a lot more about that during the debate over the Earned Income Tax Credit bill during the COVID crisis, and we passed legislation on that. We know that people pay taxes. How does that fact that they pay taxes, they pay into the system, would that offset the expense that's estimated in the fiscal note? If not, how can we be sure that the state of Maryland can afford to extend this coverage? Thank you.
Thank you for the question. So undocumented individuals pay every year about $308 million to the state and to local government. And a lot of times those money, they're basically used to fund programs that the undocumented community is not able to benefit from. What the fiscal note actually towards the end sort of hint is it was difficult to quantify, but would reduce the cost and makes it affordable, is the fact that many undocumented individuals end up in our emergency room, which is very costly care, the most expensive care, and that we do not quantify the prevention, right? The part of seeing a doctor early so that things can be diagnosed, like the example of the woman whose testimony was given. So you will save money. And what the fiscal note also hints, and I would submit to this committee, is that, you know, the uninsured rate right now in Maryland is 6%, and it will go down. But by expanding the insurance pool, this bill will reduce the individual market premium plans on the Maryland Health Benefit Exchange. And that is worth it because we will all benefit from that. And then finally, why wouldn't we want a healthy community? They're here, they're working, they're contributing. We have done amazing things on this committee, which I'm so proud. What, like I said yesterday and today, with the exchange and reducing, you know, the uninsured rate by more than 50%, covering people in all 24 jurisdictions, 23 counties in Baltimore City, actually stabilizing the individual insurance market, you know, finding out who's uninsured out there through the tax form. But the people that are left, over 300,000, a majority of them, 275,000 of them are our neighbors who contribute to the economy. And when they get sick, they go to the hospital. And in the end, we all pay for it.
Yes, ma'am. Madam Chair, if I may, quick follow-up.
Sure.
Vice Chair Pena-Melnick, we know that there are, we've talked a lot in this committee about medical debt and reducing the harm of medical debt. We know that undocumented Marylanders have been the subjects of medical debt lawsuits. Would this bill potentially protect those Marylanders from being victims of medical lawsuits because they had health insurance coverage?
It would, because they will be protected, because they will have insurance coverage, right, to pay their bills, and the bills won't be enormous, right? They will have some cover, and I think that helps them, and not only them but their families, the stability of being able to put food on your table, right? Pay your bills to be able to make it. And we know that medical debt is really the number one cause of people filing for bankruptcy, because it really affects them greatly.
Thank you so much, Madam Chair. Thank you.
Thank you for your questions.
Delegate Belcastro.
Thank you so much, Madam Chair, and thank you, Vice Chairman Pena-Melnick, for bringing this important bill forward. I work in a school that has a large undocumented population, and the thing that's bothered me year after year is how difficult it is to get medical forms back from my students that are undocumented, and the barrier that presents from getting them enrolled in things like sports and after-school programs and Special Olympics. And I can only think that a bill like this, if it were to pass, we would see more after-school participation from our undocumented students. So I'm wondering if you could touch on that and maybe talk on some of the other barriers that might exist for our young people and their families by not having access to care and being able to get medical forms filled out.
Yeah, it's difficult because they don't have, by not having access to care, you don't have a relationship with a doctor. Right? Like my children are blessed. They have a pediatrician. My son is 23 and he still has his pediatrician. He needs to leave her. And we told him this last year because he has a relationship with her, because she cares, right? Like when my daughter was in the hospital at Children's Hospital for a week, her pediatrician came to the hospital and she was part of the group. And it actually prevented a lot of other things that could have happened to her because she had a relationship. And these children that do not have a doctor are not able to fill that form. They're not able to stay on top of their vaccination. They're not able to have, like my kids are so blessed. They have a yearly, when you go to the doctor to have your physical, they're not able to do that. I am on top of my children to go to the dentist every 6 months. They hate it. They're not able to do that as well. And that affects their health. It affects your future, how you take care of you. And these kids really are second-class citizens. They really are.
It's really important. Thank you for putting this bill in.
Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you, Madam Vice Chair, Committee Vice Chair, for this really good bill that gives us, better quality healthcare for all residents and lowers our overall cost. The fiscal note references the waiver that California submitted requested, and then they withdrew, but yet they're still able to do this without that waiver. Do you envision that if for some, and it's not clear why their waiver was denied, can you just speak to whether the waiver is critical or just a good thing to have, and we'll be able to move forward even if we don't get the waiver?
The waiver in California, the application was withdrawn because it was during the Trump administration. And you had that anti-immigrant sentiment in this country. So that was the reason. But they do cover, they're very creative with a lot of the programs in many other states, actually California, Massachusetts, New York, North Carolina, Washington, DC, Oregon. They have similar programs to what we have here, where they have expanded Medicaid and have also a public option. So there are many other states they have realized, and they're not states that are all blue. It's bipartisan that this is important because it's important for the health of our economy and for everyone else.
Excellent. Thank you.
Thank you.
Delegate Rosenberg.
You just mentioned, Delegate, the fact that other states, blue and red, have passed similar legislation. Do we have any information on the fiscal impact? Was it, as you have indicated, the kind of savings from having people being covered with
Yeah.
this insurance?
Yeah, in the states that have passed it, you have seen a reduction in the uninsured, right? And you have also seen, most importantly, a reduction in some premiums, but most importantly, the improvement in people's health. And that is very important.
Thank you.
Delegate Johnson.
Thank you, Madam Chair. The question's for Chair Peña-Melnick. You had mentioned that we have a 6% uninsured. Does that include undocumented, or do we have any idea what the percentage is with the undocumented?
So the undocumented population is actually 4.5% of the population of the undocumented population are uninsured. 4.5% are undocumented residents. So that's nearly half of the residents that are uninsured.
All right, thank you.
My
Thank you,
pleasure.
Madam Chair.
My pleasure.
I don't see any further questions for the panel. So that concludes the hearing on House Bill 1035. Thank you to everyone for your participation. Next bill up is House Bill 1111, which is Delegate Beitzel. And I'm not sure if Delegate Beitzel is here or we have someone from his office to present. The title of the bill is Prescription Drug Monitoring Program, Prescribers of Opioids Notification Requirement. Who do we have here on this bill?
Hi, yes, I'm here. I'm Delegate Beitzel's Chief of Staff. For the record, my name is Ben Reichert. I'm here to present for him.
Welcome. Thank you. Go ahead and get started.
Okay. Good afternoon, Chair Pendergrass, Vice Chair Peña-Melnick, members of the committee. Delegate Beitzel unfortunately had a mandatory appointment at 3 p.m., so I'm here on his behalf to present HB 1111. Maryland is fortunately seeing a decline in opioid-related deaths, but more needs to be done in our state. We're not experiencing the rate of decline as other states who are adopting more aggressive measures. Still, too often, drugs containing opiates are prescribed without the patients having any knowledge of the risks of addiction. Since the passage of the HOPE Act in 2017, Maryland has failed to pass adequate legislation to ensure best practices are being followed across all areas associated with the crisis. This bill, HB 1111, the Prescription Drug Monitoring Program, Prescribers of Opioids Notification Requirement, is intended to address one area where we can make an impact. The proposed legislation would require the prescriber to notify the drug monitoring program that the prescriber has educated the patient, emphasis on the patient, on the risks of opioid use, made the patient aware an overdose reversal drug exists, and whether they dispense or prescribed an overdose reversal drug. Let me just be very clear here, because there has been some confusion related to a drafting error in this bill when we submitted it last year. This is about patient education, not prescriber education. Prescriber education has been dealt with in several other bills, but this bill is about making sure patients know their risks with these dangerous drugs. Benefits of HB 1111 include, most importantly, that measures that have been put in place to protect patients are being adhered to by prescribers. Further, it expands education to include an opioid reversal antidote like Narcan, and the State Department of Health will have access to data that enables them to monitor whether or not prescribers are in fact following best practices as determined by the state. Many of you have probably heard the story of Delegate Beitzel's son, who was in a very serious ATV accident, and his son has been dealing with opioid addiction and its effects for several years now. Virtually every family knows someone who has died from prescription painkillers containing opiates. Delegate Beitzel also wanted to share one other story from his personal life on this issue. He had minor shoulder surgery a couple years ago, pretty minor, only mild lingering pain, and his doctor gave him several prescriptions after the surgery. He went to fill them, and one of them was hydrocodone, which was way more than anything Delegate Beitzel needed for this pain. So he went back to his doctor and he said, "Why did you prescribe me this? I don't need this." Or, "Why couldn't you have at least told me that you're giving me this really dangerous addictive drug?" And his doctor told him, a sitting member of the Maryland General Assembly, "I don't care, sell them on the street if you want." So that's some of the reality that we're seeing in our state, and some of the way these prescribers are treating these drugs, which can be very, very serious and very life-changing drugs. And this bill hopes to address that issue and making sure the patients are aware of the risks involved. So thank you so much for your time for hearing this bill. We urge a favorable report on HB 1111. We now hope you listen to Kristen Stevens, a great advocate on these issues, who's been a big help on this bill. Thank you again for letting me substitute in here for Delegate Beitzel. We really appreciate your time.
So much, Ben, and please pass along to Delegate Beitzel. We are sorry he couldn't join us, but we did hear his personal stories in your presentation, and we very much appreciate them. And we will hear next from Kristen Stevens.
Hi, thank you, committee members. My name is Kristen Stevens. I live in Frederick, Maryland. I am here on behalf of SMART as a member of the Healthcare Working Group and as a concerned caregiver in support of HB 1111. SMART has offered a separate official written testimony, and so due to my limited time to testify before, I just wanted to highlight a few quick points, including the written testimony that I submitted, just noting the importance of this bill due to the existing inconsistencies. I did testify before this committee last year in support of this bill, and a report released from the CDC since that time estimated 100,000 plus overdose deaths during the 12-month period ending April 2021, which is an increase of 28.5%. The 12-month period ending September 2021 estimated 8.5% overdose increase in the state of Maryland alone. So the statistics are showing that the crisis is not waning, it's actually surging. We have acknowledged that there is a policy in place which requires certain patients to be advised of the risks and benefits of prescription opioids. And when enacted, it was a step in the right direction, but it lacks the major component of oversight. We know that medical professionals must be having these conversations with patients because, as we have learned during COVID, the healthcare professional-patient relationship is one of the most trusted. My personal experience, my mother's risks and benefits were buried in paperwork, and I was provided a website to go to among a dozen bullet points. As an educated person with privilege of knowledge in this space and receiving the discharge information, it was just completely overwhelming. I have the ability to read, I have internet access, I have college education, and I just don't know what people are supposed to do who are not in my situation with different abilities, those who are socioeconomically disadvantaged, et cetera. Additionally, it's my understanding that certain healthcare systems like Johns Hopkins University do co-prescribe naloxone, and across the state, other counties have ramped up efforts. So while checkbox may seem arbitrary, just requiring providers to check that box one time in the PDMP confirms compliance with the existing mandates and that there was education on and the offering of potentially life-saving medication. And this reminder and record is something that electronic health record cannot do. And the co-prescription is critical. And I'm actually going to run out of time, so I can't get into this.
No, Kristen, don't worry. Let me interrupt you. Ben left about a minute and a half, I think, left on his clock. So that can carry over to you, please.
All right. Okay. The reason that the co-prescription is critical is because while caring for my mother, I'd like to know that in the hospital, her O2 levels dropped to 84. And so she ended up on oxygen, and it was followed by a doctor's recommendation to be checked for sleep apnea. And so when she was home, she was so out of it that a few times she had forgotten she had taken her medication and attempted to take her painkillers multiple times, which is exactly how accidental overdoses happen. So I ended up hiding the medication and leaving behind my naloxone with a friend of hers who's a nurse who took over for me when I wasn't there. And the onus should not have been on me to provide the naloxone in the event something should happen. I didn't prescribe the opioids. I'm not the medical professional. So it's just the inconsistent application of state policies. This bill just serves as another point of patient intervention. Had my mother had the surgery at Johns Hopkins, I would not have been the responsible party that provided the naloxone. And so to date, 10 states have the co-prescription requirements along with the education legislation, and studies have shown the benefits of these practices. So we just ask, adding the box to the PMP serves as a consistent reminders to prescribers and dispensers that the patient has received what this body has already put into the statute to be followed. So I sincerely appreciate your time, and I look forward to your questions.
Thank you so much. Do we have questions from the committee? Giving everyone just a second in case there's any questions, but it looks like Delegate Hill, go ahead.
Yeah, thank you. I wanted to ask, thank you for being here. I wanted to ask Ms. Stevens, it sounds like what you're saying is that telling the part of the bill that says the prescribers have to check up a box if they gave information, you wouldn't have found particularly useful, but you think it's important to co-prescribe the naloxone. And certainly, the pharmacist gives information when the prescriptions are given out. Have you considered at all that we do a bill that says when X amount of a narcotic is given, that even without a prescription, that the naloxone is given anyway, that a patient can refuse it, but that it go to the pharmacy level and that the naloxone be distributed with X amount of a narcotic.
I'm sorry, can you repeat that one more time? I had to turn up the speaker on my computer.
Okay, sorry.
My apologies, that was my fault.
So the bill has two parts.
Yeah.
One part is that the prescriber has to certify that they've given information.
Yes,
You
ma'am.
talked about being given information and it was just overwhelming. The second part is that they also prescribe above a certain amount of narcotic, Narcan at the same time and give information about that. My question was, would your goals be better served if instead of doing it at the prescriber level, we said at the pharmacy or dispenser level, if X amount is given, that the Narcan be automatically dispensed or offered at the same time without going through the prescriber, because that's where most of the information comes from. It's the stuff that the pharmacist hands out. That's what people take home with them, and that's what they look at.
I absolutely, for me, I believe that the co-prescription is, 100% very important. When I'm talking about the education piece, like I said, I submitted my mom's medical paperwork in with my written testimony, and you can see where it is buried. And it literally is the website you go to, like, I think it was like cdc.com to go to. And so I do firmly believe in that education piece. And if it comes from the prescriber, if that's an amendment, if it comes from the dispenser, who I think that some sort of conversation needs to happen and not just handing somebody paperwork. So that is, that is of concern to me, because if I couldn't read or if I couldn't, access that website, I'm not sure what happened, but I do firmly believe in co-prescription practices. Yes. So I do
Thank
believe.
you. Thanks very much. Thank you.
Thank you. Any further questions? If not, let's move on to the unfavorable. That is Dan Doherty.
Can you hear me?
Yes, we can, Dan.
Okay. Madam Chair, I'm Dan Doherty here on behalf of the Maryland State Dental Association, opposed to House Bill 1111, not because we disagree with the intent, but because we feel it's duplicitous. Currently, anyone who prescribes a scheduled drug, it's a prerequisite under the criminal statute that they be knowledgeable about the monitored drug, including the risks associated, and that they complete 2 hours of continuing education relating to the prescribing or dispensing of controlled dangerous substances. This CE course must be approved by the prescriber's licensure board and provide information about opioid reversal agents and about morphine milligram equivalents. Secondly, section 1-223D1 of the health occupation articles requires whenever a patient is prescribed an opioid that the patient be advised of the benefits and risks associated with the opioid. If a physician or a prescriber fails to do that, the course that is open is to file a complaint with that prescriber's licensure board. They have enforcement authority. The PDMP does not. We feel that this is not the best approach to it. We feel that what's currently on the books and possibly what Delegate Hill has proposed is a better way to approach the problem. And for these reasons, we would oppose 1111, but not its intent. Thank you.
Thank you very much. Do we have questions for Mr. Doherty? Seeing no questions, that concludes the hearing on House Bill 1111. Thank you so much to everybody, and make sure to tell Delegate Beitzel you did a great job. We really appreciate you being here. I think we can squeeze one more in before our break. Let's do House Bill 1244, and then we will do our break. House Bill 1244 is Delegate Howard, Health Insurance, Lyme Disease, and Related Tick-Borne Illnesses, Long-Term Antibiotic Treatment.
Thank you, Madam Chair.
Welcome, Delegate Howard.
Thank you very much. Thank you. Good to see you all, colleagues. For the record, I'm Delegate Seth Howard, and I'm pleased to introduce to you HB 1244, which, as stated, is the Lyme Disease and Related Tick-Borne Illnesses Long-Term Antibiotic Treatment. This bill requires insurers, nonprofit health service plans, and health maintenance organizations to provide specified coverage for long-term antibiotic treatment of Lyme's disease and related tick-borne illnesses. A carrier may not deny coverage for treatment otherwise eligible for benefits solely because the treatment may be categorized as unproven, experimental, or investigational in nature. So I just want to take a moment and just real quickly read a couple of clips from the CDC and some other things that I've dug into, some groups that I've dug into, just to give you sort of a sense of scale and of where I'm coming from and what we're trying to accomplish here. From WebMD, May 7th, 2021, the first time Lyme's disease carrying ticks typically associated with woodlands in New England and other forested regions in the US have been found in abundance near beaches in Northern California. Daniel Salked, PhD, a Colorado State University research scientist who led the new study, said the findings surprised even his own team, which did not expect to discover ticks infected with Lyme disease causing bacteria on the shoreline. And the reason I say that is because per the CDC's tiering system, they have a high, moderate, and a low tiering system when it comes to Lyme's confirmed and reported cases. California is very low, I think at about 80 confirmed cases. And per the CDC, in 2019 in Maryland, there were 804 confirmed cases and 613 probable, putting Maryland in the high-risk category per the CDC. Per the CDC's website as well, treatment resistance, chronic and apparent relapsing Lyme disease with its oft-associated co-infections, which worsen the illness, though once debated, is now well documented in scientific literature. And then just one very quick one, from the CDC. Unfortunately, there is no proven treatment for PTLDS, the post-treatment of Lyme's disease. Patients with PTLDS should just basically talk to their doctor about long-term treatment and treat and managing the symptoms. I'm not trying to manage the symptoms. We want to treat this thing, and we know that we can. Lyme's has been in Maryland since '82. It was first reported in '82. And I think we all know what was going on in the 80s and the mid 90s. AIDS was at the top of everybody's list. It was the #1 killer of males, 25 to 44 in '92, and the #1 killer of all Americans in I believe 94. And look where we've come. We've come a long way in treating that. And I'm not trying to conflate this with that, but it's due to a lot of the treatment procedures, the fast tracking that went on, the call by Dr. Fauci in 1989 for the CDC to fast track alternative methods of treatment. And I really feel like we've made a lot of progress today due to some of those calls. And that's really what we're trying to accomplish with this bill, so that we can start to treat this. Through my conversations with some folks that I think are going to be unfavorable on this, and through my conversations with MIA, one of the things they talk about is the cost that would be borne by experimental treatments upon the ratepayer. And I would just say this: we do that all the time. In economic matters, we have energy policy that comes before us all the time and comes before this legislative body all the time. Gas infrastructure bills that are passed on to the ratepayer. I signed on when Vice Chair Jameson was Vice Chair of Economic Matters. I signed on to a community solar bill that would allow solar energy to and communities to patch in essentially to community solar. Some of these things are passed on to the ratepayer, and it's for the ultimate good. I mean, I think we can all agree there's some things going on within our environment. We need to get them fixed. But my point is that we do that all the time. I understand the concerns for cost, but at the end of the day, we're looking at about 1,400 Marylanders. So, I don't think that the sky is going to fall. I don't think that anything's going to burn down. But what we would be doing would be giving these Marylanders their life back. And with that, I would like to turn it over to my panel, if I could, unless the chair, unless you want the unfavorables to go or whatever.
No, we have, I'll just let you know what we have. We have Tracy O'Riordan signed up to support, and then we only have written testimony from the unfavorable.
Okay.
So let's hear from Tracy.
Okay.
Is Tracy O'Riordan here?
Yeah, I saw her on, so.
Hello, can you hear me?
Yes. Go
Good
ahead.
afternoon, everyone. Thank you for allowing me to speak. My name is Tracy O'Riordan. Thank you for pronouncing it correctly. And I am a Lyme disease sufferer for half my life. I'm 50 years old. I contracted Lyme disease in Crofton, Maryland at the age of 25. I went undiagnosed and misdiagnosed for more than 16 years because the doctors just didn't know and the insurance didn't want to pay. We burned through our savings, our 401k, just treating my daughter and I from Lyme disease because insurance didn't pay for the doctors. Insurance didn't pay for most of our medications or vitamin supplements that we needed because Lyme disease depletes you of all kinds of supplements, vitamins, minerals. I mean, calcium alone, vitamin D. I have to go out in the sun with no sunscreen and risk getting melanoma because I need the vitamin D replenished in my body because of what Lyme disease has done, because it wasn't caught soon enough. And doctors aren't trained enough. Insurance companies seem to be running the roost, unfortunately, and they don't want to pay for us. But this is an epidemic. This is around the world, yet it started here in the United States. Insurance companies should be paying for us. I mean, they pay for AIDS patients. You know, when GRID came out, does anybody know what GRID is? Gay-related immune deficiency. AIDS, HIV, y'all pay for that. Y'all pay for cancer is self-inflicted, like lung disease. We didn't do this to us. We need help. It has ruined my life, my marriage, everything. We need help.
Very much for your testimony. Do we have questions for this panel? I'm going to give the committee a second, see if there's any hands raised. Okay, I will remind the committee that there's no unfavorable panel signed up. There are 2 letters in your file on this. And with that, it concludes the hearing on House Bill 1244. Thank you all so much for being here today. We are going to take our committee break now. It is 3:25, so we will return at 3:40 to finish the last 6 bills. Thank you. Welcome back, everyone. It is 3:40 and we're about to get started. As soon as we confirm, we have everyone here for 13:55. We're going to give them a minute, and if we do not have anyone here for 13:55 within the next minute or two, I'll give it 90 seconds, split the difference. We'll move on to my two bills and see if 13:55 Delegate Cox is able to come. He's the only person testifying on that bill, so we will reach out to his office. Can we reach out to his office, please, and make sure they know we're back?
Delegate Cox just joined us, so he is here.
Perfect. Excellent timing. Thank you for joining us, Delegate Cox. HGO is just reconvening our hearings for the afternoon. So we have 6 bills left this afternoon, and we will start with House Bill 1355, which is Delegate Cox. The title is Health Insurance, Prescription Insulin Drugs, Limits on Co-Payments and Co-Insurance. Delegate Cox, you have 5 minutes. Thank you so much.
Thank you, Madam Chair and honorable members of the committee. It's an honor to present the prescription insulin drug limits on copayment and coinsurance, HB 1355. First of all, it's a great honor that the Attorney General's office has also entered a letter of support. I hope you have a second to review that. This bill will bring much needed relief to Marylanders suffering from diabetes. For those who do not suffer from the disease or have no family members who do, insulin is an expensive but life-saving treatment. According to the Healthcare Cost Institute, type 1 diabetes is a chronic condition affecting approximately 1.5 million Americans. In individuals with type 1 diabetes, the pancreas stops producing insulin. Insulin is the hormone that breaks down sugar in the blood so that it can be used by the body's other cells as fuel. And as a result, type 1 diabetics must adhere to a lifelong insulin regimen that includes administering insulin through either injections or an insulin pump. Insulin is a complex drug that is not available in generic form, though competing versions are available for some insulin products. The cause of type 1 diabetes is unknown and there is no cure. The American Diabetes Association produced a report titled Economic Costs of Diabetes in U.S. in 2017. And care for people with diagnosed diabetes accounts for 1 in 4 healthcare dollars in the United States. And more than half of that expenditure is directly attributable to diabetes. People with diagnosed diabetes incur average medical expenditures of over $16,750 per year. People with diagnosed diabetes on average have medical expenditures 2 to 3 times higher than the expenditures of other individuals that have other ongoing medical expenses. That report goes on to detail the rise in cost in diabetes drugs due to rising insulin prices. And after adjusting for inflation, economic costs of diabetes increased by 26% from 2012 to 2017 due to the increased prevalence of diabetes and the increased cost per person with diabetes. The growth in diabetes prevalence and medical costs is primarily among the population of age 65 and older. And the Healthcare Cost Institute showed that in 2016, individuals with type 1 diabetes spent over $5,700 per person on insulin. And between 2012 and 2016, gross insulin spending per person increased by $2,800. That's almost a $3,000 annual increase for insulin, larger than any other category in medical spending. This disease is prevalent in our senior population, but it also affects children. And therefore it impacts families and those who many times are the least able to afford the climbing costs of insulin. And then when we add to that concern a record-breaking inflation rate in this year, those in Maryland who suffer from diabetes are beginning to have a bleak outlook in how they have access to life-saving insulin. The Maryland General Assembly has capped the price on other medical items. This should be one of them. Diabetes can be a debilitating disease for a person's health and comfort, but it doesn't have to be a financially debilitating also. A cost cap on insulin will effectively reduce the financial weight of this disease for Marylanders. And for that, I respectfully request a favorable report on HB 1355. Thank you very much.
Thank you very much. Do we have questions for the sponsor of the bill? I do not see any questions from the committee. So with that, let us turn to the unfavorable witness, Matt Celentano.
Thank you, Madam Chair and members of the committee. My name is Matt Celentano today here on behalf of the League of Life and Health Insurers of Maryland and AHIP, America's Health Insurance Plans, in respectful opposition to House Bill 1355. We completely understand why this bill was introduced and would never suggest that these life-saving drugs should not be more affordable. But this approach will do nothing but give Big Pharma free rein to charge carriers whatever they want and increase everyone's premium. We shouldn't need to cap drug prices. Big Pharma should just decrease the prices. It's all down to the list price, especially in insulin. The problem is right there, the list price. The drug was invented for about $2 about 100 years ago, and the price has skyrocketed to multiple $100s a month with not a bit of new research and development. There's simply no oversight or control on what they can charge. Simply, excessive and unreasonable drug prices have fueled this crisis in our country. The carriers also believe that insulin is the poster child for the Prescription Drug Affordability Board that you all created a few years ago. There is no drug that highlights the need for a second look on unjustifiable price increases as insulin, and request that you ask the PDAB to focus on insulin within the study language portion of this bill without the cap. That being said, if this policy moves forward, you're going to take out the legs of the 5 commercial carriers that have been actively negotiating with the manufacturers to provide their beneficiaries low-cost insulin. 4.54, depending on how you look at out of 5 of the carriers, have already varying deals in place with manufacturers. If you pass this bill, you'll take away the ability of the market to continue the progress without impacting premium. The negotiating leverage will be taken away in an instant. Like I said before, we understand why this bill is here, but we are worried about the impact of the fully insured market, which this bill only applies to 18% of the market, and giving Big Pharma a further license to steal. So we respectfully request an unfavorable report. Thank you very much.
Thank you. Do we have questions for Mr. Celentano? I see no questions from the committee. So that concludes the hearing on House Bill 1355. Thank you so much. Moving right along, we are going to hear House Bill 1208, which is a Delegate Kelly bill, Health Occupations, Healthcare Workforce Expansion. It's called Workforce Expansion, but it's actually a nursing bill. Let me tell you about it as I start my 5-minute clock. It's hard to multitask here. So thanks everybody for allowing me to present this bill, which is another piece of our efforts to address the healthcare workforce crisis. We've heard from a lot of stakeholders about the shortage of nursing staff and a situation that has been made worse by licensing and testing delays caused by the cyber attack. And there are a lot of non-legislative efforts underway right now to address this crisis. Nursing schools are adding more slots to accommodate more students. They're recruiting additional faculty. Hospitals are offering increased schedule flexibility, wages, signing bonuses to attract and retain nursing staff. But there's still a significant challenge. So at the suggestion of the vice chair, over the interim, I met with stakeholders to discuss the crisis, and a few of the ideas stemming from those discussions are reflected in this bill. It doesn't contain everything that we've been discussing, but this is what we thought we could work with legislation this session. I really want to thank Lindsay Rowe, who has been supporting that effort and pulled together this legislation very quickly and thoughtfully. So I'm going to just go through a couple of the things that are in the bill, and then you'll hear from stakeholders. You'll also hear that we probably need to refine this a little bit more with some amendments. Again, this is sort of a living document, and we needed to meet that bill drop deadline. So during the pandemic, the Maryland Institute for Emergency Medical Services Systems ran a clinical externship program, which placed 1,400 nursing students and 100 respiratory therapy students in clinical externship positions at hospitals and facilities across the state. A waiver issued during the crisis allowed students who completed certain coursework but not yet completed the required testing to work under supervision of a licensed professional. And the program was very successful, particularly in rural areas. So this bill continues the program, but places it under the supervision of the Board of Nursing instead of MIMS, which I think the stakeholders felt was more appropriate. Another of the challenges we identified in the shortage of nurses was a shortage of nurses willing to serve as preceptors, and that impacts the availability of clinical placements for nursing students. In 2016, to address a similar problem with physician training, we established a tax credit against state income taxes for physicians and PAs who serve as preceptors. So 1208 expands the program to offer tax credits for licensed practical nurses, nurse practitioners, registered nurses in the hopes of attracting additional nursing preceptors. Visiting restrictions were put in place during the pandemic, if you all remember, and many long-term care facilities hired patients' family members and as temporary nursing aides. This had the dual benefit of allowing family members to see their loved ones and assisted the facilities in meeting the workforce needs. Over 3,100 individuals have taken the 8-hour course to become employed as a temporary nursing assistant, and approximately 2,000 remain employed in our long-term care facilities. But once pandemic-related waivers expire, this workforce needs to transition to become CNAs. HB 1208, this bill, authorizes the Board of Nursing to apply on-the-job experience towards the training hours required. This is a really important fix. You're going to hear from stakeholders about why we need to do this. HB 1208 requires the Board of Nursing to create and implement a marketing plan to attract individuals to the field of nursing, and also create supported on its website a resource for potential nurses to find information on pathways to licensure or certification, things like that. I think we need a little more discussion around this piece. The legislation is going to convene a work group to study expansion of the state apprentice programs to healthcare workforce and make recommendations, et cetera. So there's a lot contained in this bill. Some of it is really, really important. Some of it is ideas that we're still finessing, and so we may need to tweak. In addition of, you're going to hear from the Board of Nursing and the Maryland Nurses Association about some amendments. So we definitely want to work with them on those amendments. So obviously I was just reading my talking points there, but I hope the committee can understand that this is a group of stakeholders who has been working together really diligently and purposefully to help address the nursing workforce crisis. I really thank the stakeholders for their participation over many months to try and come up with some substantive changes that we need to make, and their continued commitment to working on this. And with that, I'm going to pass it off to the panel. We'll start with Erin Dorian from the Maryland Hospital Association, and hear from several other folks. And thanks everyone, and urge a favorable report. Erin Dorian.
Thank you, Delegate Kelly, Madam Chair, members of the committee. For the record, Erin Dorian, on behalf of the Maryland Hospital Association and our 60 hospital and health system members. I want to thank you, Delegate Kelly, for being a champion for the healthcare workforce this year and bringing together that group over the summer and spending a lot of time with us. You have my written testimony, but I want to highlight one particular provision that we are excited about, the Nurse Extern Program. This program began during the COVID-19 pandemic and allowed some nursing students to work across the healthcare sector in both hospitals and in local health departments in supportive roles commensurate with their level of education. There are students, these students are still supervised at work, so they can learn as they earn. This is a win-win for the healthcare system and the nursing students. We're really happy that this is being moved to the Board of Nursing and hopefully being set up in a more permanent fashion. We look forward to working on this bill with the other stakeholders and their amendments as it moves forward, and we urge a favorable report.
Thank you so much. Next, we have Allison Siborowski.
Thank you, Madam Chair. I am Allison Siborowski here today on behalf of Leading Age Maryland in support of House Bill 1208, and you have our written testimony. Thank you, Chair Kelly, for involving Leading Age Maryland in these conversations. It's been great to be involved. We represent more than 135 nonprofit aging services providers in the state. And we all know that a strong workforce is essential and that we need more solutions. And we feel that this bill lays out several strategies that can be beneficial specifically for nursing assistants and licensed nurses in Maryland to help us grow a stronger workforce. We know that our workforce has faced shortages for years. We also know that most of the direct care workforce and nursing workforce are women, and that they have been disproportionately affected throughout the pandemic. And so anything that we can do to further bolster and support this workforce is vital. And I'll just note that many of our members regularly report high numbers of nursing vacancies, and difficulty with finding RNs and LPNs. So this has forced many to have to go to staffing agencies, but even the staffing agencies now do not have staff available. So for all of these reasons, we really feel that this bill takes an important step in acknowledging these challenges and providing benefits. So for these reasons, we respectfully request a favorable report.
Thank you. Next, we have Dana Kaufman.
Thank you very much, Chair Kelly, members of the committee. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network, and we thank Delegate Kelly for convening the work group over the interim. I'm going to focus my comments on one provision of the bill, and that is the provision that requires the Maryland Board of Nursing to allow an individual who has been practicing as a nursing assistant, a temporary nursing assistant, to apply the on-the-job experience that they have gained toward the total number of training hours required for certification. During the pandemic, right in the beginning of the pandemic, actually, I think it was in March, CMS issued blanket waivers to the states to try to address the worker shortages that were already anticipated and that were occurring. And they allowed individuals to work as temporary nursing assistants. Some of these individuals have been now working for 2 years, and we have been working to get them fully certified. But given their experience that they have and given the extreme need that we have for workers, we really want to create a pathway for these individuals who have now on-the-job experience to be able to use that experience, use that time that they have put into the job, and have that be applied to their training requirements and their other certification. I understand that the Board of Nursing has been working on this issue. It's my understanding as well that the conversations have been positive. So we really do hope that in the near future, there can be a pathway. We thank the Board of Nursing for their attention to this very important issue. Thank you.
Next, Robin Elliott.
Good afternoon, Chair Kelly and members of the committee. Robin Elliott here on behalf of the Maryland Nurses Association. Very much strong support of this bill. We, as Chair Kelly mentioned, we do have a few technical amendments, but we think they're very minor. I wanted to emphasize two pieces of the legislation. The first is the preceptorship tax credit. It has been a long-standing challenge for nurses, nursing students to get clinical placements, and that was just made so much worse by the pandemic. But this is a long-term problem, and this tax credit idea is a real solution to help address that. The second is at the end of the bill, in uncodified language, there is a study around apprenticeship programs and whether or not the resources in the model under the Department of Labor may also support the healthcare world. I want to mention specifically community health workers as a type of healthcare profession that might benefit in terms of support and numbers from that study ultimately. So we ask for a favorable report, and we look forward to working with the committee.
Very much. And finally, we have Karen Evans from the Board of Nursing. Hi, Karen.
Hi, how are you? Thank you so much, everyone. Thank you, Delegate Kelly, for working with the board and others to make this bill happen. Greatly appreciated. And thank you, Madam Chair and board members. I'm Karen Evans, the Executive Director for the Maryland Board of Nursing. We are in support of this bill. We have just a few amendments that we would like to make. The first is for the marketing piece. For the marketing, since the board oversees and enforces and regulate disciplines, it feels that it would be in conflict of interest. However, I think we can have a compromise on that as far as adding more information so that individuals know what path, and we feel that that also will be better served by the Maryland Nurses Association. The second is concerning the clinical externship. The board feels that it is duplicative, but what I would like to offer Delegate Kelly is one, for the board to work with both long-term care acute care in the schools of nursing to develop a program that I think will suffice as instead of doing the clinical extern, hopefully think out of the box so that we're able to do that. And so I would like to pursue that and be able to provide you with updates as we go through that particular process, getting the appropriate stakeholders in. The last is the board is in support of the TNAs. We just asked that one line be added and just to amend it slightly to include that TNAs were authorized to work pursuant to CMS waivers and that their designation will cease once a public health emergency. And yes, we have put together, I think, a wonderful compromise for the TNA. And I think everyone in long-term care would love it once we give it to them. So we work diligently to help everyone. And thank you for your time. And we hope for a favorable report on this bill. Thank you.
Thank you, Karen. And thank you to everybody who was involved in this work over the interim and to Delegate Pena-Melnick for suggesting we start doing this. I think we made some progress. Delegate Kerr.
Thank you, Madam Chair. I have a question regarding the apprenticeship aspects of the bill. Nurses, we've all seen play an essential public service. So do police, so do the members of our military. Yet we ask nurses to pay for their own education, but we don't ask soldiers and police to pay for their own education. So I guess my question is, who pays the tuition, fees, books, uniforms, and cost of equipment for nurses in an apprenticeship program?
So I can attempt to answer that question. Let me just say that this is, the apprenticeship model as it applies to healthcare is a question that I think the state is interested in figuring out how it works. And I think it works better for certain health occupations than for others. But the crux of your question is actually language. I just saw a proposed amendment on a different workforce bill that's asking sort of exactly that question. I think over the next few years, the state is going to be spending a lot of time trying to figure out how to best make the apprenticeship model work in healthcare. So the short answer to your question is we don't know those answers yet, and we want to be respectful of the different that the model works differently for different health occupations.
Yeah, thank you. Just one more point I'd like to make is that nursing especially lends itself to an apprenticeship model because you have the stackable credentials. So a student nurse in an apprenticeship program is of some professional value to you while he or she is continuing the education. And I hope we can work this out.
Thank you. Delegate Hill.
Thank you, Madam Chair. Just curious, what's the difference between the student nurse and the externs as you're proposing it here? Is it just a matter that the externs can get paid and the student nurses don't because they're both supervised? I'm just trying to, what's the difference?
Why don't we have Erin Dorian explain a little bit more about how the externships worked?
Sure. So thank you for that question, Delegate Hill. The way that that it worked during COVID was that they were actually able to come in and provide supervised care. It's sort of outside of the clinical expectation of their education. So it was in addition to their education and they got paid for it. So it is separate from, I mean, they might be doing a little bit more under supervision during their clinicals where they're still learning how to do things. And then, when they are working as in an externship, they're just doing sort of up to the level of education that they have, still supervised, but they are sort of behaving more in an externship program as nurse extenders, where in their clinical that it's still a very educational process. And if you'd like me to get some more information about how hospitals use them or health departments, I'd be happy to do so.
If you offline, yeah, I'm not seeing quite where the difference is. And the follow-up is, when you all met, did you also look at the international nurses? I know for many years we had a lot of nurses supplementing our workforce, for instance, from the Philippines. And then I think the federal government clamped down on visas. And I didn't know if that was an impact on our nursing force as well. And if you're looking, or this bill might give a way to look at some of that.
We did not, we spoke a little bit in the beginning, but really what we were looking for in this initial piece of legislation was what are the short-term fixes we need right now? And then with the plan of continuing over the interim to look longer term. So I would certainly agree that we should include that in the longer term conversation.
Thank you.
And I think I need to ask a question of Robin Elliott. I think my question for Robin Elliott would be, do you have something important to add to this conversation?
So it's a great question about nurses from out of the country. I'll note that you have another bill before you. It's House Bill 625. It's the commission to look at workforce shortages. And I think that is definitely one of the topics that should be discussed by that commission. Probably not just for nursing, but other professions as well.
What an excellent reminder, Robin Elliott, of another bill that I have that I forgot about. Thank you. It's that time in session. I don't see any more questions. So I think with that, we will conclude the hearing, and I will thank all the panelists for their contributions on this, concluding the hearing on House Bill 1208. Next up is House Bill 1241, not as kumbaya, a bill from Delegate Kelly, Health Occupations Nursing Home Administrator Qualifications. This bill came to me again late, right before the deadline, so it is not all worked out, and I apologize to the committee for that. But it is also in the theme of taking steps to address the workforce crisis, so I think it is important that we have this conversation now. What the legislation does is it expands the workforce by allowing more reciprocity of licensed individuals between states with provisions that are similar to those that were implemented during the pandemic. And it removes barriers to entry by giving professional credit to applicants who are licensed and experienced in another role, and to applicants who have a degree in healthcare or in aging. For context, because I'm not sure if I read this in the title, we're talking about nursing home administrators. It removes barriers to entry. The legislation does not remove the requirement to pass the written qualification exam, nor does it remove any other requirements such as character and background checks. The bill will allow Maryland facilities to train their own leaders more quickly and recruit from other states while upholding educational and exam requirements. This week, I have received letters from several facilities, and I'll just quote one here. It said that the rules and processes associated with becoming an administrator in Maryland have been incredibly challenging, and it limits the top talent that we can recruit. We've been forced to turn away countless qualified professionals due to overly burdensome process. You are going to hear, again, in this hearing, opposition and concerns from the Board of Nursing Home Examiners. And there's also opposition from the Office of the Long-Term Care Ombudsman, as well as a letter from the AG's Consumer Protection Office. So clearly we need to have some more conversations about how exactly to accomplish this goal. But we are going to convene a meeting with stakeholders and see what can be done to address their concerns so that hopefully we can move forward with the intent of this bill, which is to increase the pool of people who are qualified and capable of being our nursing home administrators. With that, I will turn to the panel on this one. I have, is Joe D'Amatos here? I think he was having trouble with his link. Do we have him?
Can you hear me?
Excellent. Welcome, Joe. Yes.
Thank you. Go ahead. You want me to go now?
Yes, please.
So real quick, we lost internet right like a minute ago, so I'm on my phone. Thank you, Madam Chair, members of the committee. I'm Joe D'Amatos with the Health Facilities Association of Maryland. We're the largest, oldest nationally affiliated association in Maryland, representing skilled nursing and rehab centers. We thank you, Chair Kelly, for introducing this bill. And I'm thankful to be joined by my colleagues from Lifespan and Leading Age Maryland in support of the bill. You have our written testimony, so I'm going to rush to summarize, especially since we took a little bit on that intro. HB 1241 does two things. First, it changes that BENHA shall consider interstate reciprocity instead of may consider when licensing individuals who are licensed in other states. This is in alignment with what other states do, and it's in alignment with what Maryland did during the pandemic emergency with physicians, pharmacists, and nurses. Second, it allows healthcare professionals to be given training credit for their current careers and creating a career path for those to become nursing home administrators. This is the part of the bill that I am most proud of because it allows entry-level workers in our settings who are very racially and ethnically diverse to become managers and join leadership as nursing home administrators and as regional directors. Despite there being 560 licensed administrators and 225 nursing homes in Maryland, we have long had a shortage of nursing home administrators. We have been talking with Ben Ha about this issue for years. We proposed a similar bill to this in 2020 in advance of the pandemic. We pulled it because of pressures from Ben Ha. We met with them in 2019. And thinking back, we really missed an opportunity to make some of these changes in 2020 in advance of the pandemic. Madam Chair, I just need to make one more point.
I think there's probably a minute and a half left on my clock, so by all means, take that time.
Thank you so very much. Just one more really important point. We've had the opportunity to study this issue over the last year and a half, 2 years. And this last point is very important. There are some that will claim that quality and safety will be impacted by the passage of HB 1241. And you will see in our written testimony that the data just doesn't bear that out to be true. Look, we look forward to working with all involved and for the passage of House Bill 1241. Thank you, Madam Chair.
Thank you very much. Next, we'll hear from Allison Siborowski.
Thank you, Madam Chair. I'm so glad to be here today. Allison Siborowski on behalf of Leading Age Maryland in support of House Bill 1241. You have our written testimony and we would welcome the opportunity to collaborate and partner on conversations to find a way forward on this issue. As my colleague Joe D'Amatos mentioned, nursing home administration is not immune from the workforce shortages we are seeing more broadly across the healthcare continuum. I think we might be able to argue that nursing home administrators maybe had one of the most stressful jobs over the last 2 years throughout the pandemic. And as it's been noted, this bill would bring licensure requirements more in line with other states in our region, while still requiring training, education, and experience that prepares nursing home administrators for the complex role of administration in long-term care settings. There's 2 quick points that I want to make. The first is that this bill would make nursing home administrator licensure more attainable for dedicated frontline professionals who have a passion for working in our field. I spoke this morning with the co-founder and CEO of the National Association of Healthcare Assistants, Lori Porter. Some of you may know of her. A few years ago, NACA sent a survey to their membership, and among the almost 5,000 CNAs who responded, NACA found that if money, childcare, and personal obstacles were not an issue, 6% of respondents would want to become a licensed or registered nurse, and 34% would want to become a nursing home administrator. This is huge untapped potential and also offers us an opportunity to keep really skilled and dedicated workers in our workforce by giving them a pathway. Additionally, I spoke with one of our board members, a regional director for a large not-for-profit organization who is licensed in Delaware, Illinois, Indiana, New Jersey, Pennsylvania, Maryland, and Wisconsin. And he noted that none of the extensive requirements for qualifying to sit for the state NHA exam in Maryland are matched by those other states. And that he reviewed all of the recommendations and agreed that they were reasonable and appropriate. So for all of these reasons, we request a favorable report for this bill. Thank you very much.
Thank you very much. Do we have questions from the committee for this panel? Not seeing any hands, just giving everybody a second just in case. All right, let's move on to the panel of opposition. We have first Stevan Ellis. I am not sure if Stevan is here.
Sorry,
there you are.
I am here. I apologize. I had trouble unmuting. Thank you, Madam Chair, Vice Chair, members of this committee. My name is Stevan Ellis. I represent the Office of the State Ombudsman, and I respectfully oppose this bill. As the State Long-Term Care Ombudsman, I advocate for the rights, quality of care, and quality of life of long-term care residents. The nursing home administrator license requirements help protect the residents in this state. If this bill is passed, those standards would be weakened, sacrificing the oversight provided by well-qualified trained administrators in the quality of care of residents in nursing homes. As a member of the State Board of Nursing Home Examiners, nursing home administrators, I recommend that the committee seek additional information from the board. Please note the following concerns. It would allow assistant administrators from other states to become an administrator in Maryland. The qualifications for assistant administrators, as well as the other professions cited in the bill, vary from state to state. The 1-year requirement of full-time nursing home administration is decreased to 9 months. It allows nursing experience to replace the experience of nursing home administrator experience, and nursing experience is not the same as nursing home administrator experience. Those of you that are nursing home administrators know how complex your job is, everything from managing the fiscal plant to care, everything in between. The nursing home administrator takes care of everything. It also requires the board to waive education requirements rather than give the board the discretion to determine this on a case-by-case basis, which is incredibly critical. If passed, this would lead to less qualified nursing home administrators, weaken the authority of the board, and provide less protections for residents in Maryland. I'm concerned that this would be an increase or a decrease of quality of care and quality of life, and we'd have greater concerns for very vulnerable residents in Maryland. I respectfully request this committee consider not supporting this bill, and I am interested in discussing with other stakeholders about this bill. Thank you very much.
Thank you so much. And now let's hear from Sierra Lee.
Good afternoon, everyone. My name is Sierra Lee. I'm the Executive Director of the Maryland Board of Examiners of Nursing Home Administrators. And I would first like to thank Madam Chair Kelly, Delegate Kelly, for this opportunity, as well as Vice Chair and the Health Government Operations Committee for giving me this opportunity to provide testimony for House Bill 1241. Respectfully, I come to emphasize the board's opposition towards the bill for the following reasons. A, the bill does not adhere to the board's mission to protect Maryland's citizens. B, it undermines the state regulations set forth to promote and provide quality care for long-term care residents. And C, it diminishes the quality and standards of candidates who will one day serve as nursing home administrators in Maryland. There are two options for individuals who are interested in becoming licensed nursing home administrators in Maryland. First, or the first option, to apply for the Administrator in Training AIT program, and the second option to apply for endorsement licensure if they are currently holding a nursing home administrator license in another state. Under the current qualifications to apply for an endorsement license, applicants must have at least 1 year of experience as a nursing home administrator of record. House Bill 1241 would reduce that required experience significantly. Additionally, there are other states that currently require more than 1 year of licensed nursing home administrator experience for out-of-state applicants. For instance, New York requires verification of at least 2 years of full-time experience in the preceding 5 years, while Washington, D.C. requires such applicants to have at least 3 years of current practice as a nursing home administrator to be eligible for such licensure. To date, there are currently 507 active nursing home administrators licensed in Maryland and only 226 licensed nursing home facilities in this state. It is also noteworthy to disclose that 0 endorsement applications received by the board office have been denied since fiscal year 2020. Furthermore, our board offers a 90-day provisional license option to non-licensed individuals working temporarily to work as an interim nursing home administrator for facilities who have lost administrators of records due to unforeseen circumstances. Essentially, House Bill 1241 undermines the current provisions that make sure that our state license qualified individuals to protect our residents and excel successfully in the nursing home administrator role. For this reason, the board is requesting for an unfavorable vote for House Bill 1241. Thank you. And I will answer any questions that you have.
Thank you so much. Do we have any questions from the committee for this opposition panel? Give me a second. I do see one. I see two. Delegate Cullison.
Thank you very much, Madam Chair. And I think my question is for Sierra Lee.
Yes.
And I was looking at the letter of opposition from the Attorney General's office, and the last paragraph speaks to shortages and deficiencies and all sorts of issues in nursing homes. So I guess, and then you explained in your testimony, you said that there was an interim program where you allowed people without those kinds of qualifications to substitute until you could get a replacement for an administrator.
Correct.
I'm just, so would you be willing to work with a sponsor to figure out how to create a professional development program that gets more people into those positions that meet our qualifications, and then perhaps could use some of those folks that Delegate Kelly's bill is looking for to develop the people to fill those positions? Because it seems to me we've got dire needs, and I'm not hearing any suggestions about how to fix those needs right now.
Well, thank you, Delegate. Thank you for your question. I think there are ways that we could address some of those needs. And those other ways that we could address those needs, I mean, there could be additional AIT programs that are provided, administrator and training programs that are provided by the nursing home companies. They can pay those AITs because it's really hard and difficult for individuals to stop work completely to, make sure that, to actually work in do the internship, the AIT internship for a whole year. So it would be a very nice caveat if, these nursing home companies can provide paid opportunities for AITs. Another way we can actually start marketing towards the demographic, the younger demographic, and at universities and schools about the profession of being a nursing home administrator. We could use multiple advertising strategies and modalities, such as the board offers we offer, just for convenience of nursing home companies and organizations, we will post licensed nursing home administrator positions, open positions on our website for free, as well as AIT positions. And then I think also we can provide, or organizations can provide, incentives for preceptors in the state of Maryland to actually mentor the AIT candidates. Also, I think we also need to start taking a look at federal and state regulations related to the facility licensure and deficiencies. We know that deficiencies are on the rise. And so, and we know that the regulations are becoming more stringent, and that's partly due to COVID. So that's something we, as a state need to take a look at, and organizations also need to take a look at. But yes, we as a board would be willing to have a discussion or a meeting with the sponsors regarding this matter.
Thank you. I mean, it sounds like some good suggestions, but I think we also need to examine where the pool of people come from. But I hope that you'll continue to work on this. Thank you, Madam Chair.
Absolutely. Delegate Krebs.
Thank you, Madam Chair, and thank you to Delegate Collison for asking one of my two questions. So now I only have one, because I agree with you. We need to find some solutions here, and this is one that's on the table. And this, I guess, question is to Ms. Lee. And if you got some better suggestions, we're willing to listen. But I think HFAM testified the fact that we have all these reciprocity bills with all these other physicians and nurses assistants and pharmacists with other states. And it's sort of the way, there was some resistance at the beginning when we started doing it, but now I think we couldn't live without it, especially during COVID. So the question is, given that we're not in unprecedented territory here, I see you, in your testimony, you talked about the different states that have more than 1 year of nursing home administrator record experience, and then some have less, blah, blah, blah. And it's like, so one of the issues is, what's the sweet spot? Why, if some have 3 or 4, maybe we should have 3. We have 1. How do you determine what that sweet spot is versus just it's 1 or it's 3 or it's 9 months? I mean, it's based on performance and outcomes. So how do you judge that? How do you determine that or reevaluate it?
And that's something we could take a look at too. But our regulations right now, they state 1 year. And then we also have, as a board, the board makes determinations on, we have our standards as far as education. So we take a look at if the individual has a bachelor's degree in healthcare administration, or if they actually, I prefer to answer this question at the subcommittee meeting.
Okay, thank you. And Ms.
Thank
Ellis, I'm
you.
not going to ask you a question, but if you have your testimony in writing, I'd love to have it because it's nice to look at, like during the subcommittee. If you have it, forward it to the committee. But thank you both very much.
I would be happy
Absolutely.
to.
Thank
Thank
you.
you.
Thank you. Any more questions? I don't see any more hands up. So thank you to everybody who came to testify on this bill. That concludes the hearing on House Bill 1241. We have 3 more to go. Delegate Bandari is up next. House Bill 1219, Delegate Bandari, pharmacists, status as healthcare providers and reimbursement. Delegate Bandari.
Thank you, Madam Chair and members of the Health and Government Operations Committee. For the record, I'm Delegate Harry Bandari, Baltimore County District 8 with HB 1219. This bill addresses a disparity in reimbursement for care services between pharmacists and other healthcare providers. Maryland pharmacists offer practices and services that enhance access to care and clinical outcomes, but they are not reimbursed by payers for these services, unlike other providers. This bill does not affect scope of practice for pharmacists, but rather seeks to ensure that they are properly reimbursed for services that are already reimbursed under state law when administered by other healthcare providers. We know that pharmacists are one of the most accessible and community-facing healthcare providers in the state. Most Marylanders live within 5 miles of a pharmacy. Needless to say, they are essential to health of our neighborhoods. During the COVID-19 pandemic, pharmacists were integral to the delivery of public health services, including administering immunization, administering COVID-19 therapies, COVID-19 testing, and telehealth management of chronic diseases. Our pharmacists remained open and accessible during the pandemic, and pharmacists worked closely with other healthcare providers to enhance quality of care, improve health and outcome, and save money for patients and the healthcare system. Despite all this, Maryland lacks a mechanism to properly reimburse pharmacists for many of the critical services they provide to patients, such as point-of-care testing, screening for certain health conditions, administration of some medications, and managing many chronic diseases like diabetes, hypertension, and heart failure. Lack of reimbursement is one of the most significant barriers to further expansion of clinical services offered by pharmacists and exacerbate healthcare provider shortages, are disproportionately impacting patients who are already underserved. Madam Chair and esteemed committee, our healthcare system in Maryland is strong, but we are falling behind over a dozen states on the issue of pay parity for pharmacists. Numerous studies show substantial system-wide return on investment for funding invested in clinical pharmacy services. There is no opposition on this bill. MedCai supports the bill with an amendment. In light of this all, I request a favorable report from the committee, and thank you everyone who are here to testify on this bill.
Thank you, Delegate Bandari. Next, we will hear from Magali Rodriguez de Bittner.
Yeah, good afternoon, honorable members of the committee. My name is Magali Rodriguez de Bittner. I'm an associate dean and executive director of the Center for Innovative Pharmacy Solutions at the University of Maryland School of Pharmacy. I'm a pharmacist and I live in District 31B. I see 2 of my delegates here, and I practice in Maryland for 39 years. I have provided care at the Veterans Administration Medical Center, primary care physician practices, and community pharmacists. And I have directly seen the impact that pharmacists' patient care services have on patient lives and physician practices. I have witnessed the struggles we have had for many years to expand these services and make them a routine and sustainable services to all patients in Maryland. Outside the VA, the lack of recognition of pharmacists as healthcare providers and the lack of reimbursement for these clinical services by Medicaid and healthcare plans are major impediments to make them sustainable and increase access to these services. In our center, we have partnered for many years with many stakeholders, developing pharmacist programs for the care of patients with chronic diseases. These programs have improved patients' health and well-being while reducing unnecessary healthcare costs. We have seen return of investment of $4 to $5 for every dollar that companies like McCormick Spices spend on pharmacy services. We have seen decrease in readmissions of 66% with savings of about $560,000 in 1 month for the health system. In spite of all of these, many of these programs could not be sustained or expanded because of the lack of reimbursement for these services within the current business models in Maryland. Currently, we're partnering with the Maryland Primary Care Program. We're working with 400 primary care physicians and 38 primary care practices in Maryland that are integrating pharmacy services, but are struggling to make them sustainable without a change in the way pharmacies are reimbursed for these services in Maryland. The president of the Calvert Medicine Group has said it well. Our patients need pharmacy services. This is the best program we have added to our physician practice in years, and we must reform healthcare payments for these services now. This is particularly true with the shortage that we are seeing and will see in primary care providers, the needs in rural communities, and the aging of our population that will benefit tremendously from these services. Pharmacists are trained, willing, and able to contribute to the clinical care of our patients in collaboration with physicians and other healthcare providers. We have the evidence that this works, reduces costs, improves lives, and we must facilitate the implementation and expansion of these services by approving House Bill 1219. And I thank you for your attention.
Thank you so much. Just so the committee knows, I let the sponsors extra time go to that panelist. Next up, we have Huai Antrong.
Yes, I'm here. Good afternoon. Thank you, Delegate Kelly, and thank you all the delegates for your time to be here today. Also, I want to acknowledge Delegate Bandari for sponsoring this bill on behalf of the pharmacists. To follow my colleague, Dr. Magali Rodriguez de Bidner, I'm Huai Antrong. I'm a professor and director of public health at the University of Maryland Eastern Shore. On the Eastern Shore, the three lower county and Somerset County. I'm here to share with you not this data and the statistic because my fellow colleague, our executive director, Aliyah Horton, will provide also, but to tell you a couple of stories about patients. First of all, I'm a pharmacist for over 17 years, and my previous practice clinic was with the Primary Care Coalition of Montgomery County that is funded by Montgomery County there in the district, several districts in Montgomery County. I also am a volunteer with the Maryland Response Medical Reserve Corps, as well as the national level FEMA clinic, and was deployed several times for vaccine clinic. And one of the times that I went to provide a vaccine in one of the clinic in Montgomery County, I got COVID myself and brought it home to my wife and my two daughters also. So the reason I say that is not because I'm not willing to go to do all the work and to bring home, but when everything is closed, pharmacy remain open. The pharmacists remain open. I have many family members who've been hospitalized, and they sometimes have issue with accessibility. The healthcare system, the primary care physician are overwhelmed. So we pharmacists are ready, willing, and able to step up and help to provide the access to care. I'm also on the Eastern Shore. Many times it's very difficult to get an appointment, the issue of access. So the pharmacists are able to provide the access that the patient not able to schedule with the other medical provider. When you go to any office visit, they usually say when payment is expected, when service are rendered. But I'm going to say that if you walk into any pharmacy, and you ask any pharmacist, they will answer your question, help you with consultation, whether on your medication, on your disease, on your medical condition. So hopefully, I speak in favor of this bill and you support this bill so we can reimburse pharmacists so they can continue to have this sustainable provide access for the patient. Thank you for your time and the opportunity. And I know that I'm out of time. Thank you.
Thank you so much. I believe that Nicole Brandt is not here. Is that right? Nicole is not here. Okay, so our last.
Yes, could I just make just one quick comment on her behalf? She's not
No,
there.
I have you signed up next, Aaliyah. You're to speak. So
Just going to say something about her. That's all.
Sure. Okay. Do you want to?
Yeah, I just wanted to mention that she had to leave for class, but she does have written testimony. It's joint with her and the chair of geriatric services at MedStar Good Samaritan Hospital. We couldn't get it cleared by corporate in time to submit formally for the hearing. So I will share it with the committee when we're done with any additional follow-up.
Excellent. Thank you. And now we will go ahead and go to you, Aaliyah Horton, and you are the final panelist on this bill. As the sponsor mentioned, there's no opposition signed up. Go ahead.
Thank you. Good afternoon. My name is Aaliyah Horton. I am the executive director of the Maryland Pharmacists Association. We're the largest association for pharmacists, pharmacy technicians, and student pharmacists in the state. I have submitted written testimony, and it is also supported by the Maryland Pharmacy Coalition, which includes all the major state-based pharmacy-related organizations in the state. So basically, this bill, as Delegate Bandari mentioned, and thank you for sponsoring this bill, is that this has two primary purposes: to recognize pharmacists as healthcare providers in health general. We are not in that list. And the second is to ensure that pharmacists are paid for pharmacist administered patient care services. Again, not a scope bill, but for what is already available to be provided. As the committee knows, pharmacists have been challenged by the predatory practices of PBMs, and it has created an economic issue for pharmacies. This is one way to address some of the financial concerns of pharmacists by allowing them to be reimbursed for their clinical services. So this bill can close a financial gap in pharmacies and treatment gaps that are happening around the state. And it's not just community pharmacies, it's health systems, substance abuse treatment centers, medical practices, as well as community health clinics that will benefit from this. And it will basically allow them to better leverage the resources they have while improving patient care and reducing costs. In my testimony, you'll see the references, but pharmacists provided patient care services have a return on investment of 25 to 1, as high as 25 to 1 to as low as 4 to 1. And I would say that 4 to 1 is still rather significant. And so we asked a favorable report, and I'm happy to answer any questions. Oh, the fiscal note is good. I should just mention that the fiscal note is a good one for us for this bill. Thank you.
I'm talking on mute. Excellent. Thank you so much. Do we have questions from the committee? I don't see any hands up. And this is sort of uncharacteristic of our committee, but I'm getting message from committee staff that we do have an extra witness who is signed up but did not show up on my list, who is George Tolley. And I do not know what position he is signed up in. Is George here?
Yes, Madam Chair Kelly, I am here. I'm here favorable with amendments. And I appreciate very much the opportunity to speak to you, Vice Chair Mpeni-Melnick, to the whole committee, including especially my own delegate from District 33, Delegate Bagnall. My name is George Tolley. I'm here on behalf of the Maryland Association for Justice with a very brief and I think simple amendment. You have heard, and we agree that this bill is directed to adding pharmacists to the list of healthcare providers in the Health General article and to helping pharmacists get reimbursed for the care that they provide. And we think that's great, and we have no opposition to any of that. But this bill as drafted does one other thing. On page 2, lines 18 to 28, this bill also adds pharmacists to the list of healthcare providers who are entitled to special tort protections under the Maryland Healthcare Malpractice Claims Act. Bills that sought to add pharmacists to that act in the past have been rejected by your colleagues in the Judiciary Committee and in the Judicial Proceedings Committee on the Senate side. There's been no evidence and no showing and no claim that pharmacists are having difficulty getting insurance or getting coverage, or that there are big verdicts, or that there are a lot of malpractice suits. There's no reason to add them to that act and no basis for adding them to that act. And if the point of this bill is to add them to that act, this bill would have been jointly referred to the Judiciary Committee like every other malpractice bill gets jointly referred. So we ask respectfully that the pharmacists should get paid. We don't want to get in the way of this bill. Just strike out those 11 lines from 18 to 28 on page 2, and that will fix the bill. Nobody has told you even that the bill is intended to expand tort protections for pharmacists. And so that's not necessary to help pharmacists get paid. And there's no reason to do it. And so we ask that our amendment be taken. We've sent that amendment to the sponsor, Delegate Bandari, and I appreciate very much the chance to present. Thank you so much for your time and attention.
Excellent. Thank you so much. Do we have questions for Mr. Talley? Don't see any hands up. Okay, so with that, we're concluding the hearing on House Bill 1219. Thank you to everyone. Moving right along, we have Delegate Smith, Health Occupations. It's House Bill 1318, Health Occupations, Mental Health Services, Cultural Competency, and Diversity. Delegate Smith, welcome.
Thank you for having me, Madam Chair. Again, for the record, I'm Delegate Stephanie Smith, and I'm presenting House Bill 1318. I bring greetings, I'm regularly in appropriations, but I'm happy to be back in HGO. I'm happy to be with both Madam's Chair and Vice Chair and the full committee. House Bill 1318 is addressing a longstanding problem we've had in this country concerning the diversity of the mental health and behavioral health employment pipeline. I know that there have been many incredible efforts from this committee specifically as recently as last year to encourage all healthcare providers to have continuing education around implicit bias. And I hope that this bill is seen as something that builds upon the great work of this committee on these issues. So what this bill does is in many ways look at some other state efforts across the country, notably in Minnesota, where in 2021, they passed groundbreaking legislation to strengthen their own diversity and cultural competency framework for their mental health workforce. And it was really looking at how can we not only strengthen the understanding for those who are already presently engaged in behavioral health work along that continuum of care, but also encourage more underrepresented professionals to pursue these careers across the continuum of employment opportunities. So the mission of this bill is twofold: increase the competency around issues of race, ethnicity, LGBTQ, and other underrepresented identities, but also ensure that we have more people of those underrepresented groups present in the mental health and behavioral health workforce. So this bill achieves that in the following ways. House Bill 1318 would require the state boards of professional counselors and therapists, the State Board of Examiners of Psychologists, and the State Board of Social Work Examiners to have a certain number of members on their respective boards that represent underrepresented communities. Because we believe at every step of oversight, we need to ensure that a varied amount of perspectives are present. It also requires these same professional licensures to include, hold on, my computer is about to die on me, to require that there be 6 credit hours related to cultural competency provided upon the renewal of the respective licenses. Now, as you know, with the implicit bias licensure that was required, continuing education credits that were required from last year's bill, that could very well be part of achieving 3 out of those 6 continuing education credits. But nonetheless, we want to ensure that each of these licensing bodies are able to also identify other opportunities to enhance the cultural competency of their respective professionals. Because the work to create a sustainable pipeline that is both diverse and enough, because we have an overall dearth of licensed mental health professionals in general, to ensure that we're doing our best around this work, this bill also establishes the culturally informed and culturally responsive mental health task force, as well as an alternative mental health professional licensing Pathways Work Group. And the reason why the Alternative Mental Health Professionals Licensing Pathways Work Group is incredibly important is that those community members who have proximity to some of those that are often treated by those that are treated that are represented in other licensing bodies. There is sometimes a chasm and a gap between those who have certain lived experience as well as other kind of peer training, helping them to build upon some of that to attain other licenses so that they can grow in their professional understanding. We want to ensure that we're not creating unnecessary impediments to people who want to pursue behavioral health careers simply because we're not providing some very well-intentioned and very well thought out alternative pathways to licensing. These particular task force would also be provided with appropriate funding to carry out their work. And then last but not least, we want to ensure that there's two specific funding mechanisms for one, people who could receive loan forgiveness under the Janet L. Hoffman Loan Assistance Repayment Program. We want to strengthen those funding opportunities across all mental health pursuits, not just those that are explicitly outlined currently in the Janet L. Hoffman Loan Assistance Repayment Program, and then also establish a grant program specifically to provide support for continuing education to increase the diversity of those who serve as supervisors of the credits needed to attain the effective licensures mentioned earlier. So this bill is very important because even prior to COVID, very much showing the mental health landscape being very challenging for Americans writ large, there was already a deficit and a disparity in terms of the needs of particularly non-white Americans receiving the mental health assistance that they need. As recently as 2020, CDC released a mental health survey that showed that 48% of non-Hispanic Black Americans and 46% of Hispanic Latino Americans experienced adverse behavioral health symptoms, indicating higher levels of mental health distress than their white counterparts. But at the same time, they were also finding obstacles to receiving the mental health care and interventions that they needed. And the National Academy for State Health Policy noted that efforts among policymakers to address the recruitment and retention efforts for underrepresented professionals in mental and behavioral health would be critical to reducing some of these disparities, namely discussing that systemic factors that foster disparities like the lack of diversity among providers is something that we should be focusing on, because in many ways there are often stronger outcomes when clinicians and clients have similar backgrounds. So
Delegate Smith, I'm going to thank you so much. If you could wrap up and we'll move on to the rest of your panel, I would really appreciate it.
So thank you so much for your time. And I do hope that you'll give careful consideration to House Bill 1318. Thank you for having me.
Very much for this bill. I see we are joined by Baltimore City Council Member Zeke Cohen. Are you here?
Yes.
Welcome. Let's hear from you now.
Thank you so much, Chair Kelly, and thank you, Delegate Smith, for your leadership in advancing this important bill. As we stare down the barrel of an impending mental health crisis caused by the pandemic and the continued unrest of racial injustice in our country, this legislation is critical and urgent. We need to completely rethink how we train, certify, and support clinicians and build a workforce that can meet the enormous challenge of this moment. I'm proud to have sponsored and passed the first bill in the country to make a major city trauma-informed through legislation. The Healing City Act has compelled us in Baltimore to completely retrain our city government to recognize the symptoms of trauma and to respond in a way that is compassionate and culturally responsive and affirming instead of just punitive. It is a massive shift in how we do business. Maryland needs a similarly seismic cultural shift in how we develop and nurture our mental health workforce. According to the Anxiety and Depression Association of America, Black Americans are 20% more likely to report serious psychological distress than white Americans. Yet, they are less likely to use mental health services. Why is that? In part, it's because historically, mental health, the field, has treated Black people as inferior. In the 18th century, Benjamin Rush, who is often considered the father of American psychiatry, held the belief that Black skin was the result of a mild form of leprosy. That deeply racist misconception was baked into the field. We know that having a culturally competent clinician, ideally one who shares some of a person's lived experiences, makes an enormous difference in helping people heal. We've seen that in Baltimore with our Trauma-Informed Care Task Force that's reflective of the communities we serve, and the Culturally Informed and Culturally Responsive Mental Health Task Force could do similar wonders for Maryland. We also know that historically LGBTQ persons have been pathologized and treated like they are broken within the mental health field. They are not broken. What's broken is a system that tells our gay, lesbian, bi, trans, and queer brothers, sisters, and siblings that they are less worthy than any other human being of love and dignity. Having a clinician that is culturally competent can make an enormous difference in restoring a person's sense of self-worth. Please pass this bill. Thank you.
Thank you very much. Do we have now with us Maura Cyphers?
Yes, thank you so much, Madam Chair. Good
Welcome.
afternoon, members of the committee. Maura Cyphers with Compass Government Relations here on behalf of NAMI Maryland. NAMI Maryland, the National Alliance on Mental Illness, is the nation's largest grassroots mental health advocacy organization. We're here today in strong support of House Bill 1318. This bill is going to help Maryland build a mental health workforce that embraces cultural competency and helps reflect the patients they serve from a variety of ways. Loan repayment, which is very important, especially in a field where we need all the help we can get. We need more providers in Maryland. We really support stakeholder input with a focus on breaking down barriers to licensure and creating opportunities for our existing workforce to become more culturally competent and aware. And additional continuing ed requirements for our provider workforce. And, NAMI has placed a strong focus on cultural competency because when a mental health professional understands that the role cultural differences play in the diagnosis of a condition, incorporates the cultural needs and differences into a person's care, it significantly improves outcomes. And we know that our culture, beliefs, sexual identity, values, race, and language all affect how we perceive and experience mental health conditions. In fact, cultural differences can influence what treatments, coping mechanisms, and supports work for a patient. So it is therefore essential for culture and identity to be a part of the conversation as we discuss both mental health and mental health care. We really thank Delegate Smith for bringing this bill, and NAMI Maryland strongly supports House Bill 1318. Thank you.
Very much. It is my understanding that we do not right now have Bobby Holmes. Is that right? We have other panelists. I just want to make sure that I'm not passing over Bobby Holmes. Let's move on to Margot Quinlan.
Great. Thank you, Chair, Vice Chair, members of the committee. My name is Margot Quinlan with the Mental Health Association of Maryland. We are here in support of this bill, and thank you to Delegate Smith for your leadership on this. I think as this committee knows fully well, we are facing a behavioral health workforce crisis, and it is really imperative in this moment that we build, train, and retain a culturally competent and diverse workforce. And so we believe that this bill is a really important step in helping us to meet that goal. Studies show that underrepresented minority behavioral health providers are just much more likely to meet the needs of underserved populations. In turn, a more diverse behavioral health workforce leads to greater patient satisfaction. And it's also worth noting that the diversity of organizational leadership also has proven positive outcomes for the recruitment and retention of people of color and diverse workforce, as well as creating safe and inclusive work environments where all employees can thrive. I think we all know well that that structural racism, not race itself, but structural racism creates these widening generational health disparities for Black and Brown Marylanders, and the impacts of discrimination, redlining, and segregation, of historical and contemporary traumas all contribute to these fatally disproportionate health outcomes, which play out in our healthcare systems, but also much of which land on our behavioral health providers to support. The impacts of racism on mental health have been linked to adverse childhood experiences, or ACEs, have been shown to have lasting impacts on individuals well into older adulthood. And this often presents itself in overdiagnosing and misdiagnosing of mental illnesses, of an increased likelihood that Black and brown youth end up in detention instead of treatment. And really, with a growing and urgent need for a diverse and culturally informed behavioral health workforce, and as Maryland becomes increasingly diverse, we see this bill as particularly timely and of critical importance. And so for these reasons, the Mental Health Association supports House Bill 1318 and urges a favorable report. Thank you.
Thank you very much. Now we have Brian Sims.
Thank you, Delegate Kelly, and good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Brian Sims, Director of Quality and Health Improvement at the Maryland Hospital Association. And on behalf of MHA's 60-member hospitals and health systems, I appreciate the opportunity to comment in support of House Bill 1318. Now, as a part of MHA's commitment to racial equity, Maryland hospitals are committed to embracing culturally competent care and approaches to both care delivery and services inside and outside of our hospitals. Bias, both implicit and explicit in healthcare, is well documented, as you heard some of the panelists speak to a second ago. And we know some of the things that work to address these issues. House Bill 1318 does two main things to advance these efforts. One, by increasing cultural and social representation among boards relating to mental health services and establishing the culturally informed and culturally responsive mental health task force. This bill helps to address stigma that exists in marginalized communities and breaks down some of the biases and inequities that have existed in healthcare for generations. Two, by creating the Alternative Mental Health Professional Licensing Pathways Workgroup, that was a mouthful, and creating a grant program for continuing education and loan forgiveness. This bill acknowledges the importance of creating diverse pipelines for mental health services professionals. And it really helps to address Maryland's staggering healthcare workforce crisis, which includes the behavioral health workforce, which you've heard others here say today as well. So by breaking down historic barriers for underrepresented populations to enter the profession is not only a necessary investment in our workforce, but it's also necessary to meet the care needs of the entire population. And so for these reasons, we urge a favorable report on House Bill 1318. Thank you.
Thank you so much. Do we have questions for the proponents on this legislation? I'm not seeing any hands up, just making sure people have a second. Okay, so let's move on to the favorable with amendment witness. That is Scott Tiffin.
Thank you, Madam Chair and members of the committee. Again, my name is Scott Tiffin. I'm here on behalf of the licensed clinical professional counselors of Maryland. We are in strong support of the vast majority of this bill and think it's an extremely important bill for this year. We strongly believe that Marylanders are only going to be best served if our workforce for behavioral health providers reflects the diversity of the patient population in the state. We also support all efforts to increase the diversity of the provider workforce in order to do that. We also believe that folks who maybe want to become behavioral health workers but work from underrepresented communities should be supported to get into the workforce and become providers. We did want to highlight maybe two questions that we had about the bill. One is related to the CEU requirements. You know, our members think that ongoing training around cultural competency is important, but we had some concerns about enumerating certain CEU requirements in statute and then reducing flexibility in the future on the CEUs that people need to take. You know, CEUs are really important for folks to keep up to date on the best treatment modalities and things like that. And so we just want to make sure there's as much flexibility for providers. And then we had some questions about the workforce that's going to be the workforce task force is going to be looking at alternatives to exams for licensure. We just weren't exactly sure how that would interact with the licensed professional counselor compact. Our understanding is that Maryland would have to license LCPCs using an exam in order to participate in the compact. So our one thought was maybe it makes sense to have that workforce only look at professions that don't have compacts, so we're not causing issues with the compacts that we're currently in. But overall, we strongly support the goals of the bill and are happy to have any conversations about ways to make it better.
Any questions for Mr. Tiffin? I don't see any hands up, so you are off the hook today, but we will still hear from Stanley Weinstein, who is signed up as unfavorable. Mr. Weinstein.
Let me unmute. Hi. I'm Dr. Stanley Weinstein. I'm the Executive Director of the Board of Social Work Examiners. And Madam Chair and committee members, thank you for allowing me to speak today. While the board supports culturally competent care and always have been, talking about social issues, social justice, and diversity, you're talking about the homework of the profession of social work. HB 1318 has many things that are of interest towards these goals, but it really doesn't meet, I think, the intent. It requires the Board of Social Work Examiners to have at least 3 members who are members of underrepresented community. We've been doing that for probably at least 10 years. I've been on the board or related to the board for 7.5, and at least every year. So there doesn't need to be a change there. However, the underrepresented community includes a group that not only includes persons of different races, but national origin, sexual orientation, gender identity, or physical ability. Are we now going to collect data on those applying to be board members on their national origin, sexual orientation, gender identity, and physical ability? The board does not think that mandatory 6 CEUs, in addition to what they've already been planning, is warranted. We have the implicit bias training that was passed last year. The board has regulations proposed waiting for a mandatory 3-credit course in bias, cultural diversity, equity. So we feel that this is already being taken care of by action of the board. HB 1318 also requires the Secretary of Health and Secretary of Human Services to convene a work group on alternative mental health professional licensing pathways. Does that mean that individuals don't require formal academic training to become licensed as a social worker, or does it mean they do not have to pass the national examination for competency, safety, and ethical practice to become a licensed social worker? The bill creates a grant program to provide for continuing education for social workers from underrepresented communities. I think a better plan would be to fund scholarships so that there is no barrier to getting the training that's necessary to become competent, professionally trained social workers. 43% today of all master's degree students in the schools of social work in Maryland are minority students. That's 43%. I can go on and talk to you about all the changes in the schools regarding diversity, inclusion, and equity that are taking place, from a homecoming program tomorrow at the School of Social Work.
Mr. Weinstein, Mr. Weinstein, we'd love to hear. No, it's okay.
But I'd be glad to demonstrate how the work is being done.
How about I'll direct a question to you since your timer is out. Why don't you tell us a little bit more about what work has been done since we have identified this as a real problem in the behavioral health community? Go ahead.
Thank you. Thank you. The School of Social Work has developed an assistant dean of diversity, equity, and inclusion. They collect and analyze data to ensure accountability on strategic priorities that address that. All incoming students have to take a course on racism that's occurred in Baltimore City over the past years. It's a requirement. The school has this Office of Diversity, Equity, and Inclusion that has school-wide impact. They have 5 staff and the assistant dean. It ties into the University of Maryland at Baltimore Professional Campus, where the president of the campus has a equity, diversity, and inclusion office. There's a lot going on, and I haven't covered Morgan yet, which Morgan has been doing work in this area for some time, and Salisbury. So I think there's a lot going on to address these issues, but the idea of other pathways I've been in touch with Minnesota, and Minnesota introduced legislation last year to develop alternative pathways, but nothing has been done since that time. So I think these are bigger questions. There's other ways to provide the education and support for underrepresented applicants. And as I say, I would prefer scholarships because the barrier is not the continuing education. The barrier is getting into school and paying for it.
Thank you very much. Do we have any other questions for this panelist? I don't see any more hands up. So with that, we will conclude the hearing on House Bill 1318. And thank you so much, Delegate Smith, for joining us today.
Thank you for the courtesy.
Okay, thanks to everyone on that panel. And we have made it to the final bill of the day, House Bill 1382, Delegate Hornberger, Children, Family Child Care Homes, and the Chief Medical Examiner, Use of Video Recording Devices and Reports, Bexley's Law. Delegate Hornberger, welcome.
Thank you, Madam Chair. And, good evening to the committee. I know we're getting later in the day, but I have a really important bill here for you to evaluate. I was approached before session from some constituents, and unfortunately, their child was at a licensed daycare facility, and that child passed away while at the facility. The parents were notified later in the day, and as you can imagine, this is the worst thing that could happen to any parent whatsoever. And unfortunately, to compound that most unfortunate that happened, it was over a year before they were notified by the medical examiner's office of what the outcome of and the result of death was. And even after that year had passed, after trying to work with Maryland State Police, with the examiner's office, it was completely inconclusive. There was reference made to potentially SIDS. However, it was not a definitive determination. And what this bill seeks to do is to try to make it so that if this does unfortunately happen again, that parents can get closure, and that the processes that we already have in place can take place in the way that they're supposed to. We actually have written in code that the medical examiner's office is supposed to provide a report within 30 days. They did not do that. The language that we have in the bill that deals with the installing of cameras is actually language that was directly copied from a bill that will most likely pass the Ways and Means Committee this year that deals with special needs students and cameras in the classrooms at public schools. Now, if you think about it, that there's not really that much difference between special needs students in the school setting and children, especially under the age of 5, in a daycare setting. And why I say that is in many instances, those children can't articulate to their parent what's going on. And if something happens, we can't go back and talk to other children. Obviously you can't talk to the other children. And in this case, the staff weren't able to answer any of the questions. So this isn't unprecedented. It is in a controlled environment. We feel that, and we have both the mother and the father here that are going to share their story with you. And we feel that, again, parroting the language that's going to be used with the special needs students in the schools is a good starting point, and a way to try to cut down and curtail this lack of information of what happened. We also understand that this would place a funding mandate on daycares, and we've gotten some pushback from them, perfectly understandable. But we are exploring an amendment that would have the state subsidize and/or fund the implementation of that equipment as well as the archiving. So with that, love to take any questions. And like I said, we have the mother and father here that would like to testify and share their story with the committee. Thank you, Madam Chair.
Excellent. We do have a question from Delegate Morgan. Delegate Morgan, do you want to wait and have the parents testify first, or do you want to go ahead and ask your question, Delegate? Okay. So with that, I'll ask, we have both Gregory and Jocelyn here. Who would like to go first? Gregory or Jocelyn Rovinsky?
Hi, I'll go first. So thank you, Madam Chair and members of the committee for hearing us today. HB 1382, known to us as Bexley's Law. It's named in memory of our daughter, Bexley Alice Rovinsky. On February 9th, 2021, her and her 4-year-old sister were at the daycare, both happy, healthy. It was 12:47 that day when we received the call that she was found unresponsive. Bexley was 7 months old. She was 7 months to 21 days old. She was thriving. She was in the top percentile for growth. She was happy unless she was hungry. She had a hearty laugh, loved snuggles. She was crushing her milestones. She said, Mama at 5.5 months, Dada at 6. You know, those are milestones that we're so grateful for. The first part of our mission is to create a system to prove accountability. In the state of Maryland, infants are supposed to be checked on every 15 minutes by the provider. The provider is supposed to check position, skin color, breathing, and comfortable room temperature. It only takes a few minutes for this, or a few seconds for this check to be done. And it's supposed to be done every 15 minutes. Is that actually happening? How many are not doing it on schedule? If a provider is doing them, and there are so many that are, having video proof in the event of a tragedy would not only, clear the air for them, but also help in the investigation to determine the cause of death. The second part of our mission is communication with the medical examiner's office. It took over 11 months for us to receive our daughter's cause of death, sudden unexplained infant death, and a note regarding atypical sleep environment. And during those 11 months of our investigation, our investigating trooper called once a month. During months 7 to 9, he could not get a single answer from the medical examiner's office. It's only been recently with the help of Delegate Hornberger that we've gotten any information from them, but still no clarification. We're not seeking for rushed results. It doesn't matter the time it takes. We're just asking for communication. We're asking for 30-day updates from the ME's office. Our goal is to give peace of mind to families and to protect our providers. Thank you for your consideration.
Thank you so much for being here to share your story with us and for your testimony. And on behalf of the committee, we are so sorry for your loss. Let's hear from Gregory Rovinsky.
Thank you, Madam Chair and members of the committee. I'm sorry for hearing us today.
Take your time. Yeah.
How many of you are parents? How many of you leave your young children in the care of others to return to work? The first part of Bexley law is for closed circuit surveillance that is non-deletable for 30 to 3 months, 30 days to 3 months. We believe this would be beneficial to both families and providers. Found unresponsive. This is the phrase our provider used that will haunt us for the rest of our lives. How long was our daughter unresponsive before found? When was she last checked on? These are the questions we'll never know the answer to. For the providers who are following the 15-minute check regulations, doing everything to keep our little ones safe, things can still happen. What is the provider's proof of innocence to protect themselves in the event of tragedy? Would cameras help? By the time police and EMS arrive on the scene, there usually has been disturbance. Unintentionally, as the provider starts CPR. The American SID Institute states there is usually no way to tell the difference between suffocation and SIDS at an autopsy. The investigation of the scene is the utmost importance. If this information is so vital, accurately determine the cause of death, why wouldn't this be a necessary safety measure? Thank you.
Thank you very much for your testimony. Let's hear the question from Delegate Morgan.
Thank you. I'm on. Thank you, Madam Chair. And I do want to offer my condolences to both Mr. and Mrs. Rodziski. Sorry for your loss. My question, I guess, would be for the bill sponsor, Delegate Hornberger. Is there, so if you have a private daycare, is there anything in state law that would preclude them from offering that service? The part of the bill part of your bill dealing with the cameras and surveillance. I'm sure there would have to be some type of contractual arrangement between the parents and the provider. Is there anything stopping that from happening now?
Yeah, that's a great question. So many daycare providers, especially as you go into what I'll call sort of the gold level or the more expensive daycare providers, will send still photos or video clips every day to parents. You know, your son or daughter is participating, you know, playing with toys, etc. So this practice is already being done, but obviously there's a cost associated with it. And not every daycare provider can outlay that sort of capital to be able to provide that service. And in this case, we have extremely vulnerable children. And yes, to answer your question, there's nothing preventing from that happening now. And that's why we're looking at a funding mechanism to provide that, because I do think that daycare providers want to be held harmless. Obviously, they don't want this scrutiny on them, especially if they're doing everything right. And that's why there's two components of the bill: not only the video, but also the medical examiner piece as well, in case a tragedy like this occurs again. But great question.
Okay, thank you for answering my question. Thank you, Madam Chair. And again, my condolences to both parents.
Delegate Belcastro.
Thank you so much, Madam Chair. And Mr. and Mrs. Ravinsky, I'm really, really sorry to hear this story and everything that you've gone through. No parent should have to deal with that, and I'm really sorry. My question is for the bill sponsor. The bill that will be coming out of Ways and Means actually passed subcommittee, looking very different than how your bill is proposed. It's my understanding it will now be a 10-school pilot program, and that's because there's many questions that still exist around how much it's actually going to cost and how a program like this would be implemented in the state. I'm wondering, one, if you're aware of those changes to that program in the Ways and Means Committee, and also if you've considered all those concerns that the Ways and Means Committee has raised around this camera program in our public schools.
Yeah, great question. I actually serve on the educational subcommittee in Ways and Means. And, you know, working with the bill sponsor, this is actually where we looked to for guidance on the language as a starting point, not as it has to be this way. And, you know, being assigned to another committee, I think that's really important, because if the subcommittee here does decide to take this up, which we hope they will, they'll be able to give additional eyes on an issue that can occur in both the public school setting and the private daycare setting. Really no difference other than just the venue, right? It's in someone's home. So we're definitely open to critique, to input, and we think that it can benefit. You know, a program like this could also look at a few pilot locations, you know, dovetailed in with that funding mechanism. But you know, just hearing the bill today is adding awareness to the issue, and really appreciate the heartfelt questions. Thank you.
Thank you, Delegate Hornberger.
Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Hornberger. Mr. and Mrs.
You're on mute, Delegate.
Sorry.
Delegate Hill.
Yes, thank you, Madam Chair. Thank you, Delegate Hornberger, for this bill. Mr. and Mrs. Ravinsky, let me also extend my condolences to the both of you. Bexley looks like she was quite the charmer, quite a little angel there. And, but for Delegate Hornberger, Mrs. Ravinsky testified that she was also interested in making sure that the medical examiner's office was in contact with families. The bill as written simply says that they have to give a report 30 days after they, after they come up with a final determination. That doesn't seem to address what I heard her testifying about, the months between the time of death and when a final determination of cause was made. And I didn't know if you had any amendments you were going to be offering to try and address that in between time.
Great question. When we worked with bill drafting, that was their suggestion. This being a subject matter that I'm not an expert in, nor have I dealt with in the past, we deferred to the wisdom of bill drafting staff. we're certainly open to input again, not only on the medical examiner piece, but also the camera piece. And I would defer to the wisdom of the committee to put a finer point on that and to make sure that we preserve the intent of the family that's been impacted by this. But great question.
Thank you.
Delegate Chisholm.
Thank you, Madam Chair. And it's more of a statement than a question. And once again, to Mr. and Mrs. Rovinsky, my heart goes out to you. I pray for you. I'm sorry for your loss. But as far as the medical examiner goes, it is a problem that has been persistent. We've heard it several times in our committee, and hopefully it's being addressed. And I know it brings no comfort to you, Mr. and Mrs. Rovinsky, but we all know it's become a major issue in this state. We're trying to pass some laws now to address some of the problems that you're running into. They are just so short-staffed, and I know that's not a good excuse or an answer, but we're trying to address it, and hopefully that'll bring some sort of a relief in the future into you. But I just wanted to make that statement. Thank you, Madam Chair.
Delegate Chisholm. We do have an opposition panel, an unfavorable panel. First, we will hear from Rebecca Hancock.
Good afternoon. I'm sorry, I had trouble getting off of mute. My name is Rebecca Hancock, and I personally want to offer my condolences, Mr. and Mrs. Rubetsky. It is terrible as a family child care provider. That is the last thing that any of us want to have in our family child care home. That being said, I would like to thank the committee for hearing our oppositions to HB 1382. We have our organization represents 4,440 family child care providers and approximately 145 large family child care homes. It is always devastating to hear of a child care who is injured or dies in any type of child care setting. However, MSFCCA does not believe this legislation is the answer for preventing incidents, and this bill is not in the best interest of children or child care providers in Maryland. Two of our biggest concerns with this bill is the financial impact. As Delegate Hornberger said, with the bill calls for us to put in cameras and video recording and to store this video recording in our homes. I personally have 2 levels in my home, and I would have to, I think, have at least 7 cameras. And when I looked at the cost of them today, minimum is $599, goes up to $1,700, depending on how many cameras you need, how much recording equipment you need. You're gonna have to have somebody train you on how to use this. I am not a police officer. I don't know how to stop it. I don't know how to start it. We don't know how much the storage is gonna cost. We looked into that, and it's gonna depend on the gigabytes of how much storage you have to have and how large the files are. So that was one of our biggest concerns with our family providers. The second thing is the privacy of the children in our care and our families. I've spoken to my families. I've heard from other providers. A lot of parents do not want their children videotaped with that recording laying out there somewhere. I know that during the family daycare, we change children. I don't want those children being changed and seeing it on videotape. So that's another really big concern from one of my providers in Carroll County. Those were 2 of the biggest concerns we had with this. We also were concerned about the requirement of when it was to be viewed by a family, law enforcement agency, or the department. It didn't really specify, like, does a parent or the law enforcement or the department come in like 8 o'clock in the morning and say, we want to see this video? Then what am I supposed to do with the other children that I have in childcare? Or are you going to show up at my house at 5 o'clock in the afternoon? And then I'm going to have to tell my family, nope, we can't do anything. We have to wait till all this is done. So that was one of my personal concerns, because it was not addressed of when the provider would be notified, when somebody wanted to come in and view the bill. To view the recording. We do believe too that after talking to many, many providers, that if this bill is passed, there will be a mass exodus of family providers. I have heard from 75 providers that if this goes in, they're done. They're going to turn their license and they're going to go somewhere else. Family child care already is low paying. A lot of us do it because we love kids, but adding one more expense to us and one more regulation, it's just going to push more people out of the profession, especially when we really need it. So HBA believes that 13A, if it's passed, we will see, like I said, a large mass exodus. So we are respectfully asking for an unfavorable report on 1382. I also like to say that we have other partners that have written opposition for this legislation. It's Maryland Family Network, the Maryland State Child Care Association, SEIU Local 500, the Prince George's County Child Care Resource Center, and the Family Child Care Alliance of Maryland. So thank you for your time.
Thank you, Ms. Hancock. And I let you go over quite a bit because I got a message that Christina Push, who is the other unfavorable witness with the State Child Care Association, was not here. I just want to make sure that Christina is not here.
I'm sorry. I'm getting over a cold, so I'm sorry, my throat's all scratchy.
No, you're fine. Let me see if we have any questions for you.
Okay.
I don't see any questions, any raised hands from the committee. So with that, I will conclude the hearing on House Bill 13.
There's somebody has a question. I think Susan Lawson.
Is there a hand up? Let me see. Sorry, I see no hands up.
Susan, she didn't see your hand.
Oh no, we only take questions from members of the.
Oh no, okay, never mind.
Okay, so thank you very much. We're going to conclude the hearing on House Bill 1382. Thank you to everybody who came and testified on this bill. That is the last bill for the day, so it concludes the work for the day. I will remind the committee that we are voting. Oh, and we have hearings tomorrow, and we are voting tomorrow. So with that, have a good evening, everybody.